like schizophrenia, and there are also other disorders, like certain substance also may have these phenomena. Okay, when we discuss various substances like alcohol, cannabis, I'll discuss again what all type may be seen. Right now, other than the common hallucinations, there are certain special hallucinations as well. Okay, so there are some hallucinations which are put into this category. Now, all these hallucinations, some of them may be visual, auditory, so it could be any of those types. But there are certain characteristic features. That is why we put them under special hallucination. Okay, so I'll tell you what are the special features of these hallucinations one by one. Okay, now first is functional hallucination. Right? Okay, now I hope you understand when I use this term modality. Okay, modality means it could be in auditory modality. If someone is having auditory hallucination, we say that he is having hallucination in auditory modality. If someone has visual hallucination, we say he is having hallucination in visual modality, this is what I mean by modality. Okay, the sensory part involved. Right? Now, what is functional hallucination? Let us understand what is functional hallucination. Now, please remember that external stimulus is required to produce or to provoke the hallucination. When we will discuss functional hallucination, we say, no, before this, when I was discussing hallucination, I told you hallucinations occur on their own, isn't it? But now, because they are special hallucination, we are saying that whenever these hallucinations occur, they are produced by some stimulus. Some external real stimulus is required, although they carry all the characteristics of a hallucination. But their production requires some stimulus. Okay, one point. That is why we are putting them separately. Second important point is that the stimulus, the real stimulus which is producing the hallucination, okay, the stimulus or real stimulus in one sensory modality. Sensory modality can be audio, visual, gustatory, olfactory, tactile. Okay, that real, for example, for what could be a real stimulus? For example, patient says, doctor, whenever my cell phone rings, this is a real stimulus. Okay, so the stimulus in one sensory modality is provoking hallucination in same or different in same sensory modality. First, let's write it down, then I will explain. So there are two important points about functional hallucination which I want you to remember. One is that some external stimulus is required to produce the hallucination. Second is this external stimulus which is producing hallucination, okay, in which modality it is there, hallucination is also produced in the same modality. Okay, let me give you, everyone has written this? Right. Okay, let's write it down. Yeah, I'll explain. I'll give you an example. Okay, so let's write it down first. I'm saying is that in whatever modality the real stimulus is, hallucination is also being produced in the same modality. Right? Let me give you an example. Suppose patient says, doctor, whenever my cell phone rings, this ringing is real. It's not that he is hallucinating and he's only hearing the ringtone. No, his cell phone is actually ringing. It's a real stimulus. So patient says, doctor, whenever my cell phone rings, I hear a man talking. So doctor, whenever I get a call on my cell phone, whenever my cell phone rings, suddenly I hear a man talking around me. There is a voice which I get. Okay, so around me. But it only occurs whenever his cell phone rings or there is a real stimulus. So let us see. So this cell phone ringing, is it a hallucination? It's a real thing. It's not a hallucination. It's a real perception. Please understand. It's a real perception. Can you tell me in which modality this perception is occurring? It is auditory. So stimulus is auditory. Okay. And what is being produced? He says, I hear a voice speaking. Okay. No one else is able to hear that voice. This is hallucination. Very good. This is hallucination. And what kind of hallucination? Yes, it's an auditory hallucination. So this auditory hallucination is like a hallucination, but it is only being produced if there is a real stimulus. Otherwise, it is not occurring. So that is why we have kept it under special hallucination. Everyone understood this? Another example can be, patient says, doctor, whenever I see a traffic light, whenever I see red light, traffic light, I see a man passing by. I see a man. So again, this real stimulus is in which modality? This is a yes. This is real stimulus, visual, real. And it is provoking hallucination in which modality? Same modality. So this will be functional hallucination. In this, so if you get a question, a patient sees a man walking by whenever he switches on the light, whenever he sees his bed light, he sees a man passing by. So what they're trying to say is that this passing by man is a visual hallucination which is getting produced only by some external stimulus. Since they are in the same modality, it is functional. Clear? Right. So this is functional hallucination. Second is reflex hallucination. Second is reflex hallucination. Okay, this is also known as morbid synesthesia. This is another name. Morbid synesthesia. Morbid synesthesia. This is another name, right? Reflex hallucination. Okay. Now, again in reflex hallucination, okay, so this is the difference. Functional and reflex hallucination are same, except in functional, the hallucination which is getting produced is in the same modality as the object, real stimulus. Here it is the different. It could be any. It could be any hallucination. Okay, it could be any type of hallucination. Auditory, visual, olfactory, tactile, gustatory, any. Right? So again, let us take an example. Again, patient says, doctor, whenever my cell phone rings, okay, yeah. Right. Okay, so let's write it down, then I'll explain with the example. So everyone is getting that there is one real stimulus which is producing hallucination. That hallucination which is getting produced has the same characteristic of hallucination which we have discussed before. Only thing is it is being produced now. Okay, while earlier we were saying hallucination, but those were spontaneously, right? That is the only difference. Now, so again example. So patient says, doctor, whenever my cell phone rings, so this cell phone ringing is a real object, real stimulus. I see a man passing by. So this is a real object, and what it is doing? It is producing a hallucination. Now, if I ask you, the stimulus was in which modality? Auditory, very good. And the hallucination is in visual. It could be anything. Patient may say, doctor, whenever my cell phone rings, I get some sensation that some insects are crawling. It is tactile. So it can also produce any type. Okay. So another example, patient says, doctor, whenever I see a red light, I hear the voice of a man. So this is a real stimulus and this is a hallucination. Real stimulus in which modality? He's seeing the red light, visual, and hallucination in which? Auditory. So it is different. So it is which type? Reflex hallucination, right? It could be any type. Okay, so this is reflex hallucination. I hope this is clear. Again, such type of questions may come. Okay, yeah. Again, yes. So the patient says, doctor, whenever someone rings whenever the doorbell of my house, whenever the doorbell rings, so I hear doorbell ringing, it's real. Anybody can hear it. It's a real stimulus. Patient says, doctor, after that, I hear voice of a man talking. Okay, so whenever there is a real stimulus, it is producing a hallucination, and you can see the modalities are same. It is auditory real and the hallucination is auditory. So this is functional. Okay, if same modality functional, different modality reflex. That is the difference. Okay, so please remember this. Clear? This is again very important, such questions may come. This is very, very important, such questions may come. Okay, nowadays clinical questions are asked. So this is, again, such a beautiful question can be framed out of this concept. So this is very important. Okay. Next is what is known as extracampine hallucination. Okay, extracampine hallucinations. Okay. So what are extracampine? Okay, extracampine is basically our sensory field. Extracampine is beyond our sensory field. Okay. So extracampine means hallucination that is outside the limits of our sensory field. So please understand. So let's write it down. So basically here hallucination, again same hallucination which we had discussed are occurring, but they are beyond the sensory limits. Usually when someone comes to us and says, doctor, I am hearing voice. So those patients will say, okay, from where the voice is occurring? Again, it's occurring from external space. Patient will say, doctor, I am hearing voice coming from behind this wall. Or doctor, I am able to hear, my neighbors, okay, who is living up on the floor above. Or I can just listen to my neighbor outside. So these are hallucinations generally occur in the sensory limits. Okay, patient will say, doctor, I can see a man nearby, right in front of me. So again, these are within the sensory limits normally. But sometimes if hallucination occurs beyond the sensory limits, we say it's a extracampine hallucination. It can be any. It could be auditory, visual, any. Let me give you an example. Patient says, doctor, I can see a man behind me when I'm seeing straight. When I'm seeing straight. Okay. So what the patient is saying is, patient says, doctor, I can see a man standing behind me when I'm looking in front. Is it in a sensory, is it in a sensory limit? No. So this is a visual hallucination, but it is occurring beyond the sensory limits. So of course it is a visual hallucination, but it is a extracampine type of hallucination. Another example. Patient says, doctor, I can hear the voice of my friend. Patient says, doctor, I can hear the voice of my friend who is in USA, while patient is in Delhi. Okay, patient is not only just saying that he is hearing voice, he is saying, doctor, I am hearing voice of a friend who is in USA, who is in America, and I am in Delhi, but I can hear his voice. Again, this was beyond the sensory limits. So this is again, although it is auditory hallucination, but what type? It is extracampine auditory hallucination. Yes. No, only those two stimulus were required. This is again why it is in special hallucination, because you can see it is occurring in beyond the sensory limits. No stimulus is required here. It is simple hallucination, but beyond the sensory limits. Again, important concept. Yeah, it is occurring just like any other hallucination, but it is occurring beyond the sensory limits. Right? Normally, patient would say he is hearing voice around him, but here patient is from another continent, he is hearing the voice. Of course, that is not in the sensory limits, isn't it? So now, next is otoscopy. You can just remember this name, otoscopy. Okay. So otoscopy. What is otoscopy? Patient experience. Okay, so patient basically experience of seeing himself or oneself. Okay. Okay, so patient claims of seeing himself. We're not talking about those. We are talking about hallucinations. We're talking about hallucination. Patient is not doing any meditation. This is totally we are talking about the abnormalities. Okay. So patient says, doctor, I can see myself. So patient is seeing himself outside of his body, and also patient says that I know that this other thing is also me. So patient says, doctor, I can see myself outside of my body in the external space, and I also know that this is me. It is not someone else. So this phenomena is known as otoscopy. Yes, sometimes, of course, it can happen in certain meritatory states. People claim about it, but we're talking about disorder, problem. Okay. So just like in the image, person says that, doctor, I can see myself, and also know that this other person is also me. Okay. He knows that it is related. It is me only. Okay. So this is autoscopy. Again, these are not very common phenomena. These are unusual phenomena. That is why we are keeping them under special hallucination, right? Now, there is something known as negative autoscopy. Again, very interesting. There is something known as negative autoscopy. What is negative autoscopy? Patient says, doctor, when I stand in front of the mirror, I look in the mirror, I see nothing. So you can see in autoscopy, patient was seeing double. Here, patient is not even seeing the mirror image. Okay, so this is negative autoscopy. Okay, that is why we are calling it as negative autoscopy, right? Again, very unusual phenomenon. Another autoscopy is internal autoscopy. From the name itself, you will be able to remember. What is internal autoscopy? Patient, very good. Patient claims to see his internal organs. Internal organs. Okay, so patient says, doctor, when I look in my abdomen, I can see my stomach. I can see my liver. I can see my kidney. Okay, as if there is some CT or X-ray machine, we can see. No, but this is abnormality which is occurring to the patient. Of course, we know that it's not that he's seeing true images. It's not true. Okay, but this is what is occurring in the patient. Okay, so this is internal autoscopy. So these are autoscopies, right? Last, again, this is very interesting and very important. We will discuss this point again. So next is hypnagogic hallucination and hypnopompic hallucination. Hypnagogic and hypnopompic hallucination. Now these hallucinations, why they are special? Why they are special? Because they are occurring in certain specific time. Okay, it's a certain specific state of the patient. I'll tell you, I'll give you a way to remember also. Hypnagogic hallucinations. Okay, you can remember like this. Hypnagogic hallucination occurs. So they occur when the patient is very good, going to sleep. So patient is just about to sleep. He's going to sleep. He's about to sleep and he experienced some hallucination. It could be any auditory, visual, olfactory, gustatory, tactile, any. I'm not saying specific, any. So he says, doctor, when I'm about to sleep, I'm hearing a man speaking. Okay, then he falls asleep. This is hypnagogic. Hypnopompic, you can remember, patient says that the hallucination occurs when the patient is very good, coming out of sleep. Okay, so patient says, doctor, when the patient is waking up, he experiences these hallucinations. Okay, so patient says, doctor, whenever I'm getting up, I see a man standing, and after some time it goes. So it is occurring only in particular time, a particular state of the patient. Okay, so this is hypnagogic and hypnopompic hallucination. Can anybody tell me any sleep disorder in which you may find this? Very good, very good. Narcolepsy is a sleep disorder which we will discuss. It has 4 symptoms. One of the symptoms is this. Okay, we'll discuss again the symptoms. So one of the symptoms is this. Okay, so these are the special hallucinations. Okay, again, direct simple questions can be framed from any of them. You should know the concept at least. Okay, understand the concept at least, right? So these were, so write it down. So these were some important part of the MSc, especially mood and affect, thought and perception. Be very, very thorough with them. Very, very important for your MCQs. Now there are just few important points about the MSc which we will cover. Small topics are there. I'll just tell you what are the important things you should remember. So just write it down. Okay. So now the perception is over. So the perception in the MSc is over. Now we are discussing certain higher mental functions. So certain higher mental functions or HMF of the brain now we are checking in the patient, right? So higher certain other functions of the mind we are checking. First is orientation. First is orientation. What is orientation? Okay, so you can write down. In fact, this even if you are in medicine, your surgery, you should know this. This concept will be very handy. Okay, so what is orientation? Orientation is basically awareness of oneself and one's surrounding. That means the person is oriented about himself and about his surroundings. Okay, generally we check orientation with respect to. We check orientation with respect to time, place, and person. Okay, so basically we check orientation with respect to time, whether the person is oriented to time, place, or person. So we ask the patient, what is the day today? What is the month today? What is the year? Or what is the time? Okay, is it morning, afternoon, evening, night? So we ask about the time. So if the person is not aware of the time, so patient may say, doctor, this is 12 August 1990. Okay, so you ask what is the day today? The patient will say this is 12 August 1990. Or the patient will say, doctor, right now it is night time. Okay, or the patient will say today is Sunday. Okay, so this will tell you that patient is not oriented to time. Okay, second is not oriented to place. Suppose patient is admitted in the hospital. You ask the patient, where are you? Patient may say, doctor, I am at my workplace. Although patient is in hospital, but he is not able to identify the place. Okay, that means he is disoriented to place. Another, when he may be disoriented to person, patient, the brother is standing. You ask, okay, who is this gentleman standing in front of you? Patient may say, I don't know him. I don't know who he is. Okay, that means he is not oriented to the person. Okay, so patient may be disoriented to time, place, person, or maybe all. Okay, if any one, we will say patient is disoriented. Okay, now please remember disorientation. Disorientation, we will discuss this again. We will discuss disorientation again. Disorientation means not oriented to time, place, or person, is seen in a very, very important condition. It's a very good organic mental disorder. D for disorientation, D for delirium. Very, very important MCQ. I will talk about delirium in a while. Please remember disorientation is seen in delirium. Delirium is an organic mental disorder. Okay. So this is very small concepts we need to understand. Okay. Yeah. That there are 4 symptoms in narcolepsy. We will discuss. Sleep paralysis is one of them. So those are the 4 symptoms seen in narcolepsy. Okay. But that is a separate symptom, not related to hypnagogic, hypnopompic hallucination. Right. Next is second in the higher mental function is attention. Now all these are prospective new questions. What is attention? Very simple term. Attention means if you are able to pay, attention to a specific stimulus. Okay, then we say that you are attentive. Okay, so attention is nothing but ability to attend to some specific stimulus. Okay, so you are right now sitting. There are fan. There is noise of fan. There are certain things moving. Sometimes there is a cell phone ringing. So there may be so many noises around. But if you are able to focus on my voice, you're able to listen to me. That means I'll say you are attentive. Hopefully, all of us are attentive, right? So that is attention, right? Now, so one thing is what is attention, but what I want you to remember is how to check. How to check attention. Okay, so it is tested by a test known as digit span test. So we use a test known as digit span test. So this is an important MCQ which I want you to remember. How attention is checked by using digit span test. It has 2 components. Write the name. I'll explain you what it is. Just remember the name. Okay. So it has 2 components. One is digit forward test. One is digit forward test and other is digit backward test. It has 2 components. Digit forward and digit backward. Now just understand what does it mean. Digit forward means I give digits to the patient and I give him the instruction that he has to repeat. He has to repeat after me. For example, I tell the person 2, 7. So patient has to repeat in the forward direction. He will also repeat as 2, 7. If he is able to do it properly, I will increase the number of digits. Then I may say 3, 5, 2. Now the patient also has to repeat 3, 5, 2. If he is able to perform this test, I will say his attention is intact. This is digit forward. What is digit backward test? I give the instruction that whatever digit I am giving you, you have to repeat in the backward manner. For example, if I give the digit 2, 7, the patient has to repeat as 7, 2. If he is able to perform it, then I increase 3, 6, 2. Then he has to repeat as 2, 6, 3. Right? So this is how we check attention. So what could be the question? The question can be, a resident is interviewing a psychiatric patient and is asking to repeat certain digit in forward or in backward direction. What is the resident checking? Or what is the resident testing? What is he testing? Very good. It is attention. Attention is for short duration, for few seconds to minutes. Okay. So attention is basically for a few minutes. Okay. So this is attention. Everyone understood what kind of question is asked? Please remember this. Remember the name at least. Attention digit span test. Okay. Next is, yeah. Yeah. So there are various numbers which are there, but again I don't want you to remember. I'll tell you. Let me just tell you the number. So here we say that if the patient is able to do 6 plus minus 2, that is, if the patient is able to repeat, even 4 or 8, then we say it is normal. Okay. And again, same with digit backward, there are, but don't remember this. I don't want you to remember the details. Just remember that this is digit forward and this is digit backward, right? Then next is concentration. What is concentration? Concentration means sustained attention. Okay. So concentration is sustained attention. That is attention for a long duration. So suppose if you are able to pay attention to whatever I am saying or whatever is being written on the screen for half an hour or the last few couple of minutes or hours, then I'll say that your concentration is intact. Right? Now, how do we check concentration? Now again, the test which is used to check concentration is serial 7 subtraction test. This name I want you to remember, also sometimes known as 100 minus 7 test. Okay, serial 7 subtraction test. Remember the name. Okay, 100 minus 7 or see. What is the instruction which we give? I tell the patient that you have to subtract 7 out of 100. Okay, whatever is your answer, again subtract 7, and again whatever is the answer, again subtract 7. So the patient may say, okay, 93, then again he has to subtract 7. Again, he says 86, again 7. So if he is able to perform it, I'll say his concentration is intact. So you can see, to have good concentration, you have to pay attention for a long time. So that is why this test is used to check concentration. Okay. Then there are other tests. Definitely, then there are other tests again. So there are other tests, then there is, let us say, if the patient does not do, there are more simpler tests. It is 40 minus 3. If he is not able to do, then it is 20 minus 1 also. If he is not able to perform any of these, then what I will say is I'll give him a paper in which I'll ask him. So whenever any object comes, there are many objects, any one object, particular object comes, he has to scratch it. Okay. Yes, we can give auditory stimulus. I will say, I will read out, yes, definitely. So it will depend. So I have to give stimulus. So I will give auditory stimulus or I will use braille. So there are many things which we can do. Okay. So then there are other, that's what I'm saying, he can touch braille. I'll give him so he'll tell you. If there are no sense, of course, it is very difficult. Okay, if we will not go into the rare conditions. Yeah, there are. Okay, so yes, we have other, blind, I will say auditory. If he's not able to even hear, I'll give him touch sensation. But whenever, I'll give him this sensation is occurring. Then there are, smell. If you're able to smell. So there are many ways, again, which we can check. But this is the commoner. You don't feel that you will be asked such question. These are the common ones, right? So this is serial 7 subtraction test. 100 minus 7. Very, very important. Okay. So please remember this. Next is memory. Question has been asked from this. Recently there was a question asked from this. So how do we check memory? Okay. So memory is basically of 3 types. Memory is basically of 3 types based on the duration. There is short-term memory or working memory, also known as immediate memory. Okay, short-term memory or working memory or immediate memory. Is able to tell. We also collaborate with the family members whether it is saying is true or not. Okay, example of the question which was asked was, a resident is asking a patient, what did you had in your last meal? Okay, so he was asking, so this was the question, what did you have in the last meal? What did you eat? So suppose if I ask you, what did you had for your breakfast? Okay, so that means I'm asking certain thing which happened in the past 24 hours. And what I'm checking? I'm checking recent memory. This was your MCQ, which was asked. Very, very important. Please remember this. So again, put a hashtag over this point. Very, very important. Nowadays, questions are being asked like this. That you are interviewing a patient, patient is doing this, or you are asking this, what are you doing? Okay, what are you testing? Okay, last is remote memory. Last is remote memory. What is remote memory? Memory of the past few months or years. Okay, so if the person is able to tell memory of the past few months or years, we say is remote memory is intact. Here, what do? We ask personal information. Personal information. Okay. For example, you may ask the patient, what is the name of your school in which you studied? Okay, patient is 30-year-old, you're asking school. Okay, you're asking some detail of the past. You may ask the patient, what is the name of your wife? What are the name of your children? Okay, so all these personal questions of the past you can ask to check for remote memory. Okay, right? So this is memory. Again, very important, this, especially this, please remember, such questions have been asked. Such questions have been asked and will definitely be asked. Okay, so this was about higher mental function, right? So this is about higher mental function. Next is, so just write it down. I hope everyone has written this. Yes, everyone has written. Great. Next is under the MEC. Again, these are very small topics but have been asked previously. What is, so then we check abstract thinking. Okay, so now we check abstract thinking. What is, you must have seen, there is a painting on the wall, there is, some paint strokes are there and they call it abstract art. Okay, abstract. So we have discussed mood, perception, thought, now higher mental function and now abstract. Okay, yeah, okay. So this is separate, higher mental function over, this is separate abstract thinking. You've heard abstract art. Have you seen abstract art? There is some painting, we're not able to understand what is, some person is saying some other meaning, some is saying other. This is abstract thinking. So what is abstract thinking? Basically, ability to understand hidden meanings. Ability to understand hidden meaning or to form concepts. Okay. So abstract thinking, normally all of us have abstract thinking. We check whether it is present in the patient, intact in the patient or not. Okay, so how do we check abstract thinking? Again, very simple test which we use is proverb testing. Proverb. What is proverb? Proverbs are muhavre. Yes, they have a hidden meaning. They have a hidden meaning. So we ask proverb. For example, we may ask a patient, the proverb, beauty lies in the eyes of beholder. So what is the meaning? So basically it means that for all of us, the definition of beauty is different. For some, beauty may be different, for some other thing may appear beautiful. Okay, so beauty lies in the eyes of the beholder. So you ask a patient this, what does this mean? So what if the patient says, doctor, this means that there is a person known as beauty which is there in the eye of the beholder. Is it? So that means that person is not able to understand the hidden meaning. He is just able to understand superficially. Okay, so that is known as loss of abstract thinking. Loss of abstract thinking is also known as concrete thinking. Concrete thinking. Very, very important. This has been previous FMG exam question. This has been asked. Loss of abstract thinking is known as concrete thinking. So the example which I gave you, the abstract thinking is lost. This is concrete. That means patient is not able to see the deeper meaning. He is just able to see the outer meaning. Okay. Another example, you ask the patient, give a proverb, pen is mightier than sword. Okay. Kalam ki taakat talwar se zyada hoti hai. Okay. So, normally, so patient says, doctor, this means that if I am holding a pen and the other person is holding a weapon, sword, because I am holding a pen, I will win. Does this mean? No. It means that the power of brain is more than muscle. Right? So if the patient is not able to see the hidden meaning, then we say loss of abstract thinking, which is concrete thinking. One very important point where it is seen, loss of abstract thinking is seen in schizophrenia. This is again a hashtag point. Schizophrenia. This is a very, very important point. Please remember this. Everyone has understood this. This is a very, very important point. Very small concept, but questions have been asked. Direct questions have been asked from this. Nowadays, a lot of times you'll see memes there. The memes trend, every few weeks, there are new memes. So memes are also, basically sometimes, if you're able to understand a meme, so sometimes this also will tell that, your abstract thinking is intact. Okay. So these memes also sometimes have a hidden meaning. Right? See, Family Man 2, anyone? See? One नहीं देखा? Exam के बाद. Exam के बाद. If those who are not seen, please don't start watching it. See it after the exam. And then tell me if you are able to understand the meaning. Right? Right. So let's continue. Then second last point about. Okay. Yeah, I'll show the previous slide. Just see if you missed anything. Okay, so this is abstract thinking, right? There are many other tests. If some of you may say if patient is illiterate, does not know proverb, there are many other tests. We'll not go into the details, but this is one very common test which we use, right? Now, next is judgment. Second last part of the MSc is judgment. What is judgment? Okay, judgment is basically to choose from a given set of options for further course of action. Okay, so just like in a court, judge gives a judgment based on evidences. He gives a judgment. Okay, so similarly, what is judgment is to choose from the given set of options and choose one option and then follow it. For example, all of us wake up in the morning. You wake up in the morning and say, okay, I can watch some series on Netflix. I can call my friends. I can meet them. I can go and hang out somewhere, or I can go to the class. So then you'll see, okay, my exams are approaching, I should attend the class, so you came here. So that means your judgment is intact, right? So this is judgment. So out of the options, we choose a course of action. There are three types of judgment. Again, I want at least, one you should remember, which is the test judgment. Please, that is why I'm saying, look, if I just give you superficial knowledge, if I just tell you what is judgment and leave it here, you will get a question of test judgment, you will not be able to answer. Okay, so try to write whatever whatever I'm saying, okay, so that other than these notes, you don't have to go anywhere for psychiatry. At at least. Okay. So what is test judgment? Nowadays they are asking questions in detail. They're not asking superficial questions. Believe me. Okay, I will see the question and you will understand why we are discussing these things. Okay. Test judgment is basically we give some hypothetical situation. We give hypothetical situation and ask the person what he will do. For example, very common question which we do is, which we ask is the fire problem. Okay. So we give fire problem. What is fire problem? Basically, we tell the patient, ask the patient, what if the neighbor's house catches fire? What will you do? So patient will say, doctor, I will, assemble people. I'll call the fire brigade. I'll try to extinguish the fire. So any answer patient may choose. No one answer is right. It could be any. What if the patient says, doctor, I'll pour kerosene? What if? No, again, this will tell you, okay, the judgment is impaired. Okay, so this question was asked once. A psychiatry resident is asking a patient, what will he do if the neighbor's house catches fire? So see, he's giving a hypothetical situation and asking what the patient will do. So that is, he's trying to check the judgment. Okay, so this is test judgment. Please highlight this. Okay, I'll tell serial subtraction test in the end. Don't worry. I'll tell it again. Right. So this is test judgment. This is very important. At least remember this. Right. Any doubt? Yes. No. There are many questions. You will. There may be any. Nowadays, earlier question was that if you find when 10 years back when you do psychiatry residency, this question was asked. What will you do if you find a sealed envelope? Nowadays we see don't find any letterbox, so that question becomes sometimes irrelevant. You may find, if you see a 2-year-old, 3-year-old kid crying in front of your house, what will you do? You say, I'll kidnap him. So it is impaired judgment. You will say, I'll call the police, take him to somewhere, help him find the parents. Certain answer, those answers will be. Sometimes you say, I'll ignore. Sometimes that also nowadays people do. Okay. So yeah. So you have to see. You have to see the context. If you're not clear, you will ask, okay, why are you saying this? Okay, or what will you do again? No, later what will you do? So you have to check. Yeah. You have to see whether the judgment which you are inferring is impaired or intact. Okay. Patient will say, doctor, I will not touch the envelope. You will say, why? Because doctor, nowadays I see that a lot of infection are there in the envelope. That is a logical answer. Then patient may say, doctor, nowadays the child, maybe someone has plotted against me. So you have to see. Right? Now then personal judgment, you see the self-care of the patient. Patient is wearing very dirty clothes, there is mud all over the body. That will tell you that personal judgment is impaired. So sometimes self-care may also tell you. Okay, about the personal judgment. Sometimes you may ask question like, what will you do in the future? For example, patient is admitted. Okay, you are asking, okay, after discharge, what will you do? Some patient may say, okay, doctor, I'll start going to my work. Okay, I'll again try to, establish better relation with my family. I'll follow. So these are all correct. What if the patient says, doctor, I'll go and I'll buy an airplane. There is zero money in his bank and he's making such, such things. Again, this will tell us it is impaired judgment. And last is social judgment. Social judgment, again, we see from the behavior. Social judgment, if patient is having certain abnormal social behavior. If it is abnormal social behavior, we say the social judgment is impaired. Okay, he goes and starts slapping anyone. Okay, he's in the class, he comes in the class, starts dancing on the chair. So all these are abnormal behavior. So we'll say that the social judgment is impaired, right? But please remember in the judgment, please remember this point. I hope it is clear. Please remember this point. This is very, very important exam MCQ. Okay. Last part of the MSc is the insight. What is insight? Insight means, from the name itself, it means awareness. It means awareness about the error, that he is ill or not ill. Now we don't check insight in other specialities, like in medicine, surgery. A patient comes with pain, acute pain, abdomen in the night. You're in the casualty. Will you ask, are you aware that you are ill? He'll shout at you. Doctor, what are you asking? I haven't been, that hasn't come. But in psychiatry, there are certain illnesses in which person is not aware that he or she is ill. Okay, patient will say, doctor, I'm all right. I think my family members need treatment. You treat them. I am all right. Okay, so we check the insight. We ask, do you think that you have any illness? Are you aware that you are having any problem? Okay, so again, there are two types of illnesses in psychiatry: neurosis and psychosis. We'll just, in another 5 minutes, we'll discuss important differences between these two. One of the important differences related to insight. So we say insight is present in neurosis. So we can write down. So the insight is present in neurosis. It is present in neurosis, absent in psychosis. So neurotic disorders like anxiety disorder, patient will say, doctor, I am having trouble, please help me. The psychotic patient may be brought by the family members and he may say, doctor, I am not having any problem, but family member, whatever history they will give, when you will examine the patient, you will see that patient is having problem, but he is not accepting or he is not aware, right? So this is insight. So this was about the MSc, mental status examination. All the important points which can be asked in the exam we have discussed. Okay. Now, before coming to individual disorders, let me discuss some classification with you. Okay. Few points I want you to remember in classification. Like, again, there are two associations have given criterias. There are two associations, So suppose I have to make a diagnosis of depression. There are two criteria or associations are given criterias based on which I can make the diagnosis. Okay. So one is ICD. ICD 10. 10 is the 10th revision. What is ICD? It is International Statistical Classification of Disease. 10 means 10th revision. Okay. ICD. Okay. So ICD is basically International Statistical Classification of Diseases, 10th revision. Okay. Right. So this is given by basically WHO. This is given by World Health Organization. Okay. So this is given by WHO, World Health Organization. So basically this is, no, don't write it down. Please don't write it down. Just understand. Basically the ICD is for all the diseases and disorders. Medicine, surgery, obstetrics, pediatric, skin, and all the disorders are there in ICD. Okay, so they've made sections in which they have defined. So it's not only for psychiatric disorder, but all the disorders. Okay, there is something known as ICD 11. ICD 11 is also, again, it is, the draft is now there, ICD 10 was in 1993-94. That old it is. So now they are revising it, they are giving ICD 11. It is expected to come, the final version is expected to come in January 2022. Okay. For your exams, don't worry about it. Okay. Even if some question come, you don't worry about it right now. Right? Okay. So ICD 11. If you want, I'll just share some important changes in ICD 11, but it will again become very irrelevant if we discuss in the class. Right? So there are many changes. The important one which we'll discuss is DSM-5. Okay, so one was ICD 10, second is DSM-5. DSM-5 is basically Diagnostic and Statistical Manual. DSM, Diagnostic and Statistical Manual. Now this is only for mental disorders, 5 means it is the 5th edition. So there was 1, 2, 3, 4, now it is 5. Because psychiatric disorder understanding is improving. Okay, they are giving numbers because, again in another few years you may get ICD 6. Okay, ICD, DSM 6. ICD 11 already is coming. So as our understanding is growing, we are revising these. Okay. Now this particular one is given by APA. This is given by APA. APA is American Psychiatric Association. And this is, you can see, this was given in, this was released in 2000, very good, 2013. Okay, so this was released in 2013. So you can see it is relatively new. Compared to ICD 10, it is relatively new. So a lot of changes were made in DSM-5. So when we come to individual disorders, I'll tell you the changes. Okay. So this is, again, please remember this. So don't worry, that it is given by APA. In India, we can follow both. Okay, it's not that in India we only follow ICD. We can follow, some institutes follow ICD, some follow DSM, right? But the answer for DSM may be better answer because it is relatively new. And ICD 11, which is coming, is also making similar changes which were made in DSM 5. Okay, so if you have to prefer one, you may prefer DSM 5. Okay, so this was, important classification. You should know the names, because now when I'll be discussing about disorder, I'll say ICD 10 it is written this, DSM 5 it is written this, so you should know what is ICD and DSM. Last table, and then we'll start with the disorder. Let's try to understand difference between neurosis and psychosis. Now please understand, this classification is old. It's an older way of classifying psychiatric disorders. But still we should know this. We should still know this because many times questions are asked. Nowadays we don't say that, it's not very crystal clear that it is only neurosis and psychosis. No, but you should know this. What are the important differences? So let us discuss. First is INICET. Tell me, INICET is present in neurosis, absent in psychosis. Very good. Second is personality. Okay, I will discuss in detail about personality when I talk about personality disorder. But still, for your, just to understand what is personality, personality is the way person behaves in his day-to-day situation. All of us have a personality. All of us. I'm not saying personality disorder. Disorder is something else. But what I'm saying is all of us have a personality. For example, if I ask you, define any, give any 3-4 characteristic of any of your family members. You may say, let us say some of you may say, my mother is very shy. She's an introvert, less social. My father is outspoken, an extrovert, very loud spoken. So, there are certain, we can define each of us, we know in few adjectives. This is how we behave normally. In any situation we put, we'll behave in that same manner. Okay, so this is the personality all of us have. Okay, now suppose a person develops neurotic illness. What happens to his personality? It remains preserved. Personality is not affected. Okay, so personality remains intact. So a person with neurotic illness, his personality will be intact. While in psychotic disorder, personality may be affected. So, family members may say, doctor, now, he's not that same person anymore. He behaves very differently, as if he's a changed person altogether. Even if the illness has subsided, symptoms have decreased, still, they'll say now he does not appear the same person as he was before. His personality is affected, right? Third is reality testing. That means touch with reality. So a neurotic person has is in touch with reality. He knows what is real, what is not real. Okay, so we say that the reality testing is present in neurotic condition, while reality testing is absent. So patient may not be able to say, whether this is real, unreal. He's seeing, muttering, he's talking when no one is around. So that person may appear to live in a very unreal world. So reality testing is impaired or absent, right? Now judgment, we have already discussed. Judgment is intact in neurosis, right? We have discussed. And judgment is impaired in psychosis. Remember, what will you do if someone's house catches fire? Pour kerosene. So judgment is impaired. Okay. This last point which I want you to remember, this is very, very important. Okay. So this point, we have discussed what is delusion, what is hallucination. This is very, very important. I want you to remember this. So delusions and hallucinations are absent in neurotic illness, but they are present in psychosis. Very, very important. Delusions, hallucination we have discussed. These are absent in neurosis, present in psychosis. Right? So again, this is very important table which you should remember. Let me give you some examples like anxiety disorders. Right? anxiety disorders, right? Any anxiety disorder you can think of? Panic disorder, social phobia, yes. Okay, so anxiety disorder, right? Then OCD. Then your all disorders like somatoform disorders. Okay, so all the disorders we'll discuss like somatoform disorders. Let me write it again. Somatoform, dissociative disorder, all these disorders. Okay, just write it down. I think this step. So somatoform disorders. Okay, all the other disorders, eating disorder, we'll discuss. All those are under neurosis. Even depression. Okay, so these are some important neurotic disorder. In psychotic disorder, any psychotic disorder? Very good. Schizophrenia. Then disorders like acute psychosis, even mania. Okay, now please understand, remember I told you sometimes a patient with depression can also develop some delusion, like delusion of nihilism. Then again depression, that is severe depression or depression with psychosis can also develop. Okay, that is severe depression. So you can see, that is why I told you this classification is not very crystal clear. One disorder can go from there to there, or one can come from here to there. Okay, so it's not a very crystal clear definition or classification, but you should know it's an older way of classifying psychiatric illnesses. Okay, so again we'll discuss important disorders one by one. Everyone clear about this? Any doubt in this? Right. So we'll come to, let's start with some individual disorders. Okay, before discussing individual disorders, let me just tell you, when do we use this term disorder? Now what happens is, whenever we are doing, discussing psychiatric disorder, we start seeing, oh, these things are seen in me. What if I am having these problems? But what do we mean by disorder? Someone is only feeling sad. Is it depression or it is just normal sadness? So we will discuss. Just by saying one term, we will not be able to say. When do we call someone is having a disorder? First, if the person is fulfilling the criteria, the symptom criteria. Okay, so DSM, ICD will tell you these are the criteria. If they are present, then we'll say the patient is having depression or any other disorder. Second is duration criteria. So someone is feeling sad only for 1 day is not depression. Someone feeling sad for 2 days, not depression. We have a criteria, at least 2 weeks. Continuously 2 weeks symptoms are present, then we call it as depression. So every disorder has some duration. So it should fulfill the duration. Third, and very important, very interesting, there is impairment. There is some impairment in functioning. There is some impairment in the functioning. Functioning means social functioning, okay, or occupational functioning. Suppose patient is having depression, he now is meeting people less often. His social interaction has decreased. He is taking leaves from his work. So his functioning is getting affected. Okay, so whenever someone develops a disorder, his functioning will be impaired. It could be mild, it could be severe. For example, patient may say, doctor, nowadays I'm not able to focus in my work. I go to office, I make silly mistake. This is mild impairment. On the other hand, other patient may say, doctor, I've stopped going to work. I cannot go to my work anymore. This is severe impairment. It could be mild or moderate or severe, but there is some level of impairment will always be there. Okay, so this is how we make the diagnosis. This is how we call someone is having a disorder. Okay. Now, lastly, whenever we come across certain problems with some problems in psychiatry, so those disorders we can divide into two. Again, it was an earlier way of classifying. They would classify as organic disorders. Okay, organic disorder and no, it was in chemistry, inorganic. These are functional. Okay. organic, I'll write it again, and functional. Again, this was older way of classifying. Organic, they would say that there is some cause. There is injury, infection, some abnormality in electrolyte, sodium is low, any abnormality, any organic cause. And then they would say that there are certain disorders which have no cause. So they will call it as functional. In functional, we have discussed it is neurosis and psychosis. But please understand, this is old way. Nowadays, even in psychiatric illnesses, we know that there are certain changes. For example, in schizophrenia, we say there is changes in the dopamine levels or neurotransmitter level in the brain. Now we know there are changes, subtle changes, okay, which we are not able to pick from CTs. Even the CT scan nowadays will also show changes. So there are subtle changes. So now nothing is functional nowadays. Everything has certain causes. But this was older way. Okay. So this is the classification. Okay. So we'll start with the disorders. Okay. So again, as a very famous Indian captain would say, worry less, smile more, and don't regret. Just learn. Now, if you've seen the movie MS Dhoni, you see how much struggle he has gone through. But one thing which he has done is he has always keep moving forward, and he has achieved what he has achieved. We all know what all he has achieved, isn't it? So let us begin the next very important topic: organic mental disorders. In each exam, at least one question has been asked from this topic. Every time there were two questions in June 2021 from this topic. And if you see the notes of your past students, you'll see both the question in the notes. I'll talk about those questions. So very, very important. And I'm always telling this topic is very important. Small topic, 1 to 2 questions each time. Okay, very, very important. Organic mental disorders. Organic mental disorders. It has been now in DSM-5 a new term. So I'll tell you certain important changes which are there in DSM-5. So DSM-5 has given a new name, a better name. It says let's call them as neurocognitive disorders. Okay. Okay, so now this is a new term in DSM-5. You should know the terms. Okay, so DSM-5 calls it as neurocognitive disorder. There are 3 important disorders under this. One is delirium. So there are 3 disorders. The first 2 are very important. You may skip the third one, but the first 2 are very important. One is delirium. Second is dementia. And third is organic amnestic disorder. Okay. First is delirium, very, very important. Second is dementia, very, very important. Then third is organic amnestic disorder. I'll tell you what is organic amnestic disorder also. If you feel like, you may focus less on this, but please focus on the first 2. These are very, very important. 2 questions each year, every 6 months, the question, at least 1 question has been asked from this. Very, very important. Delirium, in your December 2020 exam, 1 question on delirium was there. I'll show you the question. Direct questions have been asked. First, let us start with delirium. Now, delirium, it is, again, please remember, it is the most common. Out of all the organic mental disorders, it is the most common. You go to any ICU setup, any good hospital, ICU hospital, you'll find at least, 1 patient of delirium there. Very, very less, when you will not find one. It is such common. Okay. So delirium, again, very, very common. It is the most common organic mental disorder. Few things which I want you to remember is, it has an acute onset. Acute means sudden onset. Suddenly the symptoms will develop. Family members will give you the history. Doctor, few hours back, he was all well. And suddenly the symptoms have started. Doctor, 1 day back, he was all well. And suddenly he is showing some abnormality. If the patient is admitted in the hospital, you may find suddenly the symptoms have developed. Okay. So this has an acute onset and has a fluctuating course. Fluctuating course means the symptoms are increasing and decreasing even in the daytime. So you'll find in morning symptoms were more, by afternoon symptoms decrease, again symptoms increase. So there is fluctuations. Okay, so it has a fluctuating course. So this is very important. It has an acute onset. Very, very important. Right now. So let us discuss before coming to the diagnostic criteria. Again, this table has proved to be very handy. Okay, when you are making in delirium, most of the time, I'll also tell you in meanwhile that what kind of question may be asked from the topic. In delirium, especially, most of the time, the questions which are asked is on the base of presentation, diagnosis. That you have to make the diagnosis. Okay. Now, before coming to the clinical features, there are certain risk factors or predisposing factors which you may find in the question, which will give you hint that okay, probably you are dealing with delirium. So what kind of these risk factors can be there? There may be patient is having some pre-existing brain damage. Okay, so there may be history of head injury. Okay, and or any other brain damage is there. Okay, so you may find there is a history of head injury, fall, patient had, so this may be a risk factor. Then patient may be of elder age group. This is very commonly given in the MCQ. A 70-year-old male, a 65-year-old female, a 50-year-old male. So the elderly age group are again more prone to developing delirium. Okay. Again, then next is patient having some chronic medical illness. Again, in the MCQ, they may give you that patient is having some illness like patient is having COPD, some chronic illness. There is hypertension or any other chronic illness patient is having. Again, the risk of delirium is increased. Okay. Now, out of all this, one point I want you to remember is surgical illness. Put a hashtag over this. In most of the time, the question which have been asked, they have given this as in the question also. Okay, so patient had a surgical illness. For example, patient had a bypass surgery. Okay, patient underwent a surgical procedure. So there was a bypass surgery, cardiac bypass surgery. Patient had esophageal rupture. Esophageal rupture. Okay, there was sudden esophageal rupture was there. Okay, patient had a fracture femur. So, big fractures. Patient had a roadside accident. Again, very commonly given in the question. Patient had an accident, roadside accident. He was admitted in the hospital. 2 days later, he developed certain symptoms. Again, all these may give you a hint that probably they are asking about delirium. Okay, sometimes they will give you surgical illness or sometimes they will give you a post-operative period. In the post-operative period, so they may give you patient underwent a surgical procedure. 2 days after the surgery, 2 days post-op, patient develops certain symptoms. 3 days post-op, patient develops symptoms. Again, they may be asking you about delirium. So this point I want you to definitely remember. I will show you a question. Again, we would discuss it each time. And a very good question in 2020 December was asked, in which they had given a patient had an appendix rupture, he went surgery. 2 days later, there were certain symptoms. They were talking about delirium. Okay, so this is one. Then some other like patient is having some substance use. Any substance you know that can lead to delirium, very good. Alcohol, very good. Alcohol withdrawal, yes. Roadside, yes. Alcohol withdrawal can lead to, so someone is consuming alcohol for a long time, suddenly stops. He may land up into delirium. So delirium because of alcohol withdrawal is known as anyone? Delirium, very good. This is altogether a very, very important topic which we will cover in substance. A lot of questions have been asked from this topic, but we will cover it separately when I'll talk about delirium of alcohol. Okay. Next is polypharmacy also. Sometimes, especially elder patient, they have hypertension, males may be having prostatomegaly. So there are many drugs on which they are. So sometimes If patient is on multiple medicines, they may also develop delirium. Again, that is a risk factor. But one risk factor which I want you to remember is this. This is very, very important. Please remember this. Clear? Please remember this point. If you don't want to remember all, please remember this fourth point. Most of the time they have given this in the question, right? Now, let's come to clinical features. Let's come to clinical features. Yeah, I'll show again. Yeah, just see. Polypharmacy means many medicines, many drugs are there. Patient is on antihypertensive, anti-diabetic medicines for prostate, many medicines are there. So again, because of multiple medicine, patient may also develop delirium, right? Everyone has written this? Yes, sir. Right. So let's come to the clinical feature now. If risk factors are there or not there, diagnosis will be made on the basis of clinical features. Let me give you a mnemonic to remember. So the mnemonic to remember is check consciousness in MSc. So the mnemonic is check consciousness in MSc. From the mnemonic, isn't it that you can tell me which is the most important symptom? Consciousness. Not unconsciousness. Patient is not unconscious. Consciousness is impaired. Consciousness is impaired. So this is very important. There is impairment. So we are discussing about clinical features of delirium. Impairment of consciousness. So consciousness is like, the orientation we were discussed. Again, it is a similar, awareness of self surrounding, consciousness. So there is impairment of consciousness. So please remember, in the MCQ, in the question, they will not, the examiners are very clever. They will not tell you patients in consciousness is impaired, make the diagnosis. No, you have to find out what is there in the question which is telling me that the consciousness is impaired. So they may use this term, there is clouding of consciousness. Clouding of consciousness. So in this table, please remember this. You will not find this in the books. In this table, I am trying to give you all the possible ways in which they will tell you that impairment of consciousness is there. So they may use this term that there is clouding of consciousness. What is clouding? That means in the clear sky, now there are some clouds. So the consciousness is now clouded. Okay. Again, this was older ways of asking question. Nowadays, they also don't use this term. So what they may tell you is that the patient is disoriented. Again, they will not tell you he is disoriented. They will give you situation and you will have to infer from it. They will tell that patient is saying that it is 1990. He is not able to identify time. He is saying he is in the hospital. He is saying he is at his home. He is disoriented to place, or he is not identifying family members. You have to see from the question. Okay, so patient may be disoriented to time, place, or person. Sometimes they may also not give you this. They may tell you that the patient is appearing confused. There is confusion. So all these are basically ways of telling you that the consciousness is impaired. Now, for your exams, let me tell you now, when I will talk about criteria, I will say that symptoms from all of these should be present. But for your examination, or even if you are seeing clinically, if the patient's consciousness is impaired, it is delirium. Don't think anything else. If the consciousness is not impaired, it can never be delirium. Simple, clear. Okay, look for it. Delirium, the consciousness impaired, delirium. Not impaired, it can never be delirium. Right? So this is one important way to, so you can differentiate. Right? Let us come to other symptoms or other clinical features. Then C for check, C for cognition. There is impairment of cognition. Okay, the cognition is also impaired. So cognition is basically, it's a bigger term which has many functions of the brain. So cognition has many functions of the brain like memory, language, perception, many. I will discuss cognition in detail when I talk about dementia. Okay, so memory may be impaired, language may be impaired, perceptual abnormality. Can you tell me any perceptual abnormality which may be seen? Very good. So visual hallucinations. Very good. So here what happened, patient is admitted into the ICU. Patient says he's seeing snakes under his bed. Very commonly seen. Okay, so patient may develop certain abnormalities in perception also. All these are part of cognition, right? But commonly visual. Okay. So this is, so I'll talk about cognition in detail again. Okay, so what are the important terms which are their domains under cognition? These are some important ones we'll discuss. Okay, then M is motor activity. M is motor activity. Okay, so again, many of the patient motor activity may be increased. So you may find a patient is admitted into the ICU, patient is removing the cannula, removing the catheter, not sitting. Sometimes we have to tie the patient or we have to sedate the patient. Is more, abnormally active, or some patient may be having significantly low motor activity. The patient is just lying down in the bed, not moving much. So it can be increased or decreased. Okay. S is sleep disturbances. Okay. So patient has sleep disturbances. Again, sleep may decrease, sleep may increase. Sometimes there is also reversal of the sleep-wake cycle. Reversal of sleep-wake cycle. What is reversal? Very good. He's sleeping in the daytime, awake at the night time. Family members say, doctor, please help. No, we are not able to sleep in the night because he is active in the night time. Please do something. Yeah, the nurse posted in the ICU will say, doctor, the symptoms are maximum in the night time. Okay, so there may be reversal as well, but it could be decrease, increase, any changes. Okay, last is E. What is E? There may be emotional changes or emotional disturbances. Okay, these patients may be having, depression, sadness, anxiety, fearfulness. So there may also be emotional disturbances. So this is how we make the diagnosis of delirium. Again, the rule which I want you to remember is impairment. Look for impairment. Look for impairment of consciousness. If the consciousness is impaired, it is delirium. If it is not impaired, it is not delirium. Please remember this. I hope everyone is clear. Yes. Good. Good. Now there is one important phenomena which is seen in these patients is sundowning. What is sundowning? Worsening of symptoms in the, very good, in the evening or the night time. So what is sundowning? As the sun go down, the symptoms increase. So family members will say, doctor, symptoms are worst in the night time. Please help us. Many times patient with delirium, family members will rush in the night time. During the daytime, they're all, they're doing nothing. You're in the casualty and you'll see most of the patients have been brought in the night time. Why? Because family members want to sleep, they're not able to sleep. There is worsening of symptoms in the night time, right? Now, I hope this is clear. Yes, right. Now, neurotransmitters involved. Right. Okay. Worsening of symptoms. Okay. This is sundowning. You may be asked this phenomena it is seen in delirium, right? Yeah. Yeah. All the symptoms, impairment of consciousness, all the symptoms may be seen. Now, please remember, when I say for the diagnosis, symptoms should be present from all the domains. But in the question, they may not give you all the symptoms. They may say a 70-year-old male had a roadside accident, admitted in the hospital. 2 days later, he's appearing confused. He's not identifying the family members. There are problems in sleeping and he's appearing anxious. Diagnosis. Delirium. He's not identifying family members. There is impairment of consciousness. Answer, delirium. Okay. Now, let's try to, integrate certain basic sciences questions. Now, so we always discuss what are the neurotransmitters involved in delirium and dementia. the question which was asked in this June 2021, which I'll come to that, they asked for changes in the neurotransmitter in dementia. What if they may now ask delirium? So you should know both. So that's why I'm saying these are very small things, but we should remember. So it may appear a basic sciences question, but you have also discussed this in your psychiatry as well. So what is the neurotransmitter which is involved? Anyone? Starts with A, any? Very good. Acetylcholine. There is a decrease in acetylcholine. Okay? Acetylcholine. Okay? So it is seen that there is, because of decrease in acetylcholine, the symptoms develop. Which neuroanatomical region or area of the brain is implicated? It is reticular formation. Okay, which is implicated. Okay, so just remember the names. Okay, at least remember this neurotransmitter. Very, very important. Okay, everyone has written this, right? Now, before coming to the treatment, there are certain tests which we can, of course, if a person with delirium comes to us, we will do all the routine tests. We'll do the CBC, we'll do the electrolyte count, KFT, LFT, sugar, because it could be because of low sodium, because of some infection. If required, we also have to do some brain imaging. Okay. Other than this, there is one test which is known as Confusion Assessment Method, or CAM. This question, when it was asked as a new question. Now, if you come across any new question, of course, if you are not able to answer, you may leave. But always try to see, can I able to infer answer from the question itself. The question was, confusion assessment method is used for. Options were depression, mania, schizophrenia, delirium. Out of these, why delirium? See the name, confusion. They are talking about some impairment in consciousness probably. So if you have to make a good guess, you can make as well. Okay, so this is used for, so basically it's a questionnaire. We see the orientation, we see how the symptoms are developed. So there are certain questions which we see, and if we get a high score, we say patient is likely to have delirium, right? Next is EEG. What is EEG? It is electro, very good, encephalo, very good. Okay, basically what is EEG doing? What do ECG do? It measures the electrical activity of the heart. So what EEG is doing, it measures the electrical activity of the brain. We put electrodes on the scalp and we measure the brain electrical activities. We get various waves, okay, and by which we infer. Okay, now please understand and remember the EEG finding, any cause of delirium, whatever may be the cause, infection, alcohol withdrawal, tumor, injury, any cause, EEG finding will remain the same. What is the EEG finding? There is diffuse slowing. There is diffuse slowing of the background cortical activity. Okay, there is slowing. Why I am telling you this? Because when you see many of your guidebooks, many of the guidebooks are saying that in certain causes the activity is increased. No, in delirium, whatever may be the cause, there is always diffuse slowing of the background cortical activity. So if there is basically electrical activities of the cortex are recorded, so those activities, so the waves are slowed. So there is slowing of waves. Okay, there is decrease in the electrical activity. Okay, so this is finding which you get in EEG, right? Now again, I tell you, delirium question most likely comes from clinical presentation. Okay, now let's come to the treatment. Now treatment again is not very specific. Treatment is not very specific. First point is to treat the underlying cause. Treat the cause, symptoms will improve. Okay, so for example, if it is because of infection, treat the infection. It is because of injury, treat the injury. It is because of low sodium, treat the cause. Okay, so first and important is treat the cause. Then sometimes we may have to use low doses of antipsychotics. Okay, so antipsychotics are drugs which we use for psychotic illnesses. We use low doses. Any antipsychotic you can think of? Very good. Haloperidol, very good. Imipramine is a antidepressant. Olanzapine, we'll discuss few of them. Pharma has been done? Yes. Right, good. Right. So these are so many antipsychotic. I'll discuss more of them. But they given low doses, especially, no, this is for symptomatic management. So suppose patient is having hallucination, patient has developed delusion, patient has developed agitation. Okay, now there was one recent question in one of the other exam. I'll show you the question maybe in the end. So the question was, in which of the following condition off-label use of antipsychotic is not used. Off-label means it is not recommended, but we can use sometimes. So they had said, in which of the following condition antipsychotic off-label use is not there. Okay, you have to say in which it is not used. One of the options was, let us say, is delirium. So in delirium, can we use antipsychotics? Yes. Yes, so we can use. Okay. Then also we can use certain benzodiazepines. Any benzodiazepine you can think of? Clonazepam, lorazepam. I will discuss more of these and benzodiazepines again, in which, when we can use benzodiazepines. Suppose patient is having insomnia. Okay. So for sedation we can use, but we don't use high doses. Please remember this. In one delirium, low doses, it will depend. It will vary. Like for example, lorazepam you can give 1 mg, 2 mg. These are lorazepam we can, in some patient we use 20 mg for some conditions. So low doses will vary. Okay. Now, can you tell me there is one delirium in which drug of choice is benzodiazepine? In one delirium, the drug of choice is benzodiazepine. Substance-related delirium? Alcohol. What was the delirium? Very good. Delirium tremens. In delirium tremens, okay, in fact, benzodiazepines are they are the drug of choice. Benzodiazepines are the drug of choice for delirium tremens. We'll discuss it, why we use it, when we'll come to substance. So this was about delirium. Okay, so this was about delirium. Again, in delirium, most of the time the question which is asked is clinical presentation. Okay, most of the time question is asked on clinical presentation. Next is, yeah, okay. Please remember this. Okay. So again, this is very important. Questions have been asked many times. If the answer is not delirium, delirium will be there as the option. So you have to see how to rule out delirium. Impairment of consciousness not seen, it is not delirium. Simple rule you can follow. Okay. Next is dementia. Okay. Now, so what is dementia? Yes, there is progressive cognitive impairment. So you can see there is impairment in cognition, but in the definition only you can see there is clear consciousness. Why we are saying clear consciousness? If consciousness is not clear, then the diagnosis is delirium. Remember, even in delirium, I told you cognitive impairment is there. So how to differentiate? Here there is only cognitive impairment. Okay, consciousness is clear. It is not impaired, right? DSM-5, the term which is used for dementia is major neurocognitive disorder. So the term used in DSM-5 is major neurocognitive disorder, right? Right, everyone has written? Okay, write it down. Now, so what happens to the prevalence with age? With age, yes, we say prevalence increases. Prevalence increases with age. So if, again, statistics says that in in a population with 65 years age, the prevalence is 5%. When we see it in 85 years age, the prevalence increases to 20%. So prevalence increases with age. It is commonly a disorder of old age. But it's not that it is only seen in old age. Sometimes even in younger age also it may be seen. Right? We'll come to that. Right? Okay, now let's come to the symptoms. Now, whenever we think about dementia, we say memory impairment. Thing which comes to our mind is memory impairment. But is it only memory impairment? No. Please understand, memory impairment is not always required. Okay, so we say the symptom, it is actually cognitive impairment. Cognitive impairment is there. So I'll discuss what all type of cognitive impairment can be seen. Okay, in this one table, I'll give you two tables. So we'll discuss two types of table in this single table so that things become easier to remember. And I'll also give you a mnemonic, but still, although I'm saying memory impairment is not necessary to make the diagnosis of dementia, but still let me give you a mnemonic. The mnemonic is memory lapse. So the mnemonic is memory lapse. Okay. So let us, so that you are able to remember. Okay, so the mnemonic is memory lapse. Okay. So the first symptom is there is impairment of memory. So memory loss is there. What is memory loss also known as? Very good. Amnesia. Okay, so there is amnesia. Very good. Right? Second is L is language. So there is problem in the language. Okay, so there is language impairment. Language impairment also known as aphasia. Very good. Aphasia. Okay. Then A is attention. Okay, especially complex attention. Okay, we know what is attention. Complex attention is when you have to pay attention to many things. For example, if you are, you're in the class, you're listening to my voice, you're seeing the screen, you're also writing. So your attention is there in many places. Okay, so patient with dementia has impairment in complex attention. So if I ask the person with dementia to come and sit in the class and attend the class, person may not be able to. Okay, either he'll be able to focus on the voice or the screen, or maybe not able to focus on any. Okay, so there is problem in attention. P is perceptual motor. Perceptual motor. So basically the perceptual motor coordination is lost. Okay, so what kind of symptoms you may get? You may get, so suppose you get in the question, person is not able to use the comb anymore. He has forgotten how to use a comb. He is not able to button or unbutton the buttons, okay, or his clothes. He is not able to put slippers, or is not able to put the shoes, not able to tie the laces. So there is problem in fine movement. What is this known as? But very good. It is apraxia. There is problem in fine movement. So many times, you will find patient with dementia is having problems in all these simple tasks. Okay. They may have difficulty to identify faces, or you ask them what is this, they may not be able to tell what is the name. Okay, they have difficulty in identifying faces, people or object. What is it known as? Agnosia. Okay, problem in identify faces or people, you can say people or objects. Okay. So there is problem in perceptual motor functioning. Okay. So all these are cognitive domains. Then fifth is S is social cognition. Social cognition. So what is social cognition? Recognition of emotions. Now they also are not able to recognize emotions of the other people. A person having dementia, someone is crying in front of that person, Normally you will ask, what happened, what is the problem? You show some empathy, but these patients will not be able to recognize the emotion. They will appear very cold. You may just sit and do nothing. So they have difficulty to recognize emotion. So, elder people, the family members will come, and say that, nowadays, they will appear very aloof. They don't, participate in the conversation, don't show emotions. Okay. So there is problem in recognition of emotion. Last is E is executive, yes, people or object. Executive functioning. Okay. What is executive functioning? So execution, executive. Okay. Chief executive officer or CEO, what is the work? They execute things. Okay. Executive functioning, that means planning or decision making. Again, that is also affected. You tell a person with dementia that, we want to go to Rishikesh, let's plan out. Let's make a plan. That person will not be able to plan because planning requires many steps. You have to call the travel agent, you have to do the booking, so all those things, these people will not be able to manage. Okay. So these are the important symptoms of cognitive impairment, which is seen in a patient with dementia. To make the diagnosis of dementia, we say abnormality should be there in 2 or more of the following. So any 2 or more of the following if are affected, we say it is dementia. So is it memory required to make the diagnosis now? No. So suppose a 70-year-old male patient, since 2 years, family members saying that he has problems in speaking. He forgets words, he's not able to use proper grammar. Okay, he's forgotten how to use a comb. He's not able to use a pen properly. Diagnosis? Dementia. Language problem? Aphasia. Unable to do fine movement? Apraxia. Okay, so this is how we can make the diagnosis of dementia. Right? So please remember this mnemonic as well. This will help you solve the MCQ. So this is dementia. To make the diagnosis, cognitive impairment is required. Only cognitive impairment. Rest symptoms may not be there. Yes. Yes, we'll discuss. We'll come to Parkinson's. We'll come to that. Okay. So now, other than this, sometimes patient may also have neuropsychiatric symptoms. Okay. In dementia, sometimes patient may also have some behavioral and psychological symptoms. No, there are many causes, multiple causes. We'll come to causes separately. Age is just one. There are many causes. We'll come to individually. I'll just come to the causes in a while. Okay. So there may be certain neuropsychiatric symptoms. For example, these patients may also appear sad. So there may be depression. There may be anxiety. Okay. So there may be many such problems. So sometimes these patients may also show certain personality changes. Okay. They may also have symptoms like hallucinations, delusions. Okay. So these symptoms may be there. But what I'm trying to say is these are not necessary to make the diagnosis. Some patient will have, some patient may not have. To make the diagnosis of dementia, what should be impaired? Cognition should be impaired. Very good. Okay. So two questions from dementia were asked in June 2021. And when we'll come to that, those are very simple questions. Okay, we'll discuss those. Okay. Now, before coming, let's discuss certain big questions. Yeah. Okay. Depression, I think we brought that movie slightly early. So depression, anxiety, personality changes, hallucination, delusion. So all the other, any symptom you can think of can be seen. Okay. These are basically behavioral and psychological symptoms of dementia. Okay. Shall we go further? Good. Now, the big question, there are certain questions which are solved. We know why Katappa killed Bahubali in part 2, but there are certain controversies which are always there. So let's talk about the controversies. let's talk about the big controversies. So what I will do is, whatever topics I am covering, I try to, resolve all the queries. So now if you find any query in any of your guides, any of your notebooks, don't worry. These are the correct answers which we have discussed, the latest answers, right? So let's solve certain queries, the most commons. Okay, these questions may come, may not come, but many a times, people are busy finding the answer. I get, we get, feedback, I've seen Harrison, I've seen the latest books. What is the most common? I'm not sure still. There is still doubt. So let's, try to solve them. Which is the most common type of dementia overall? Very good. Alzheimer's disease. Now, the controversy is not on the first, the controversy is on the second. Which is the second most common cause of dementia? There is a recent change in this. Very recent change. Earlier, we would say it is vascular dementia. Now, the answer has changed to very good, Lewy body dementia. Okay. Is more than vascular. Okay. So vascular now is the third. So earlier we would say vascular was the second most common. Now the answer is Lewy body dementia. Please remember this. It's a recent change. So they may ask you which is the most common cause of dementia. Alzheimer is not there in the option. Then go for the second most common. Okay. This is how they ask the questions. Now, so this was about the most common overall. Now, tell me what is early onset dementia? I told you dementia generally occurs in late age. But sometimes people at younger age also develop dementia. So since those are less small subgroup of population, we term them as early onset dementia. So we say onset before 65 years of age. It could occur in 30s, 40s, 50s. Okay, any onset before 65, we say it is early onset dementia, right? Now, let's come again to the most common. If I ask you for the early onset dementia, the most common cause is, answer remains the same. It is Alzheimer's. Okay, again, controversy sometimes occur with the second most common. What is the second most common cause of early onset dementia? It is frontotemporal dementia. Other name of frontotemporal dementia is also known as Pick's disease. Okay. So these are some important controversial questions which you may find. Different books may give different answer, but this is the latest which you should follow. Okay. Any other answer, don't go with that answer. Right. Now, coming to the types of dementia. Okay. Although I told you dementia is a progressive condition, it increases with time, with age it increases, but there are 15% causes or 15% of the cases which are reversible. Very important. So if in the patient you are able to find a reversible cause, it's a good sign. Treat that cause, symptoms will go away. Otherwise, we know it's an irreversible condition. Okay. Otherwise, no, it's an irreversible condition. Okay. Let me show this slide again. Okay. Okay. So these are the most commons we have discussed. Very important. Okay. Now, so some causes, again, there is a list of causes. There are many causes, but I am discussing some important common ones. One is the neurosurgical conditions. For example, there is a hemorrhage. For example, there is subdural hemorrhage. There is some hemorrhage like subdural hemorrhage, extradural hemorrhage. Okay, so there is some intracranial tumor. There is tumor in the brain, or there is some abscess. because of which the patient has developed symptoms, so we go away. Okay, so these are the neurosurgical conditions. Then there are infections. So many times infections like encephalitis. Okay, so many infections like encephalitis, neurosyphilis. Okay, so all these infections of the brain, again, most of them you treat, the symptoms will go away, right? This metabolic cause is very important, and this was, again, we would discuss this table so many times, and such a simple question was asked. They had asked which one of the following is the cause of dementia in June 2021. So out of this, some of the important metabolic causes, there is deficiency of vitamin B12, folate. Okay, so deficiency of vitamin B12, folate, even niacin. So deficiency of them leads to dementia. So this was the question which was asked. So the answer was vitamin B12 deficiency can cause dementia. June 2021 question. Okay, very simple direct question. Okay, and again certain endocrinal disorders can also lead to dementia. Again, there is a very wide list. I'm talking about certain common ones. Okay, endocrinal problems like hypothyroidism, even hyperthyroidism, hypo or hyperthyroidism, even hypo and hyper parathyroidism, PTH, parathyroidism. Okay, again, these can also lead to dementia. These are reversible causes, especially hypothyroidism. Please remember this. Again, you may be given in the question. So this is very, very important. This B12 one, again, this question was directly from the table. Very simple question, direct question. So one question was this in June 2021. We'll discuss the question in the end. Okay. Now other causes, maybe it can be because of certain substances like alcohol. Okay. Even chronic use of alcohol can lead to dementia. But if you stop alcohol, we have seen that symptoms of dementia will reverse. Okay. So again, this is very, very important, reversible cause. Okay. So this table is very important, and especially amount, such amount, chronic use, chronic over the years. Okay. Some patient may develop with 1 quarter, some may develop with 1 bottle. Okay. Okay, so these are types of dementia. Everyone has written this? Yes. Right. Now, there is one more classification. There is one more way of classifying dementia. Okay, that is cortical dementia and subcortical dementia. Okay. Cortical dementia and subcortical dementia. Okay. So cortical and subcortical dementia. So this is one more classification. Again, this question has also been asked, few years back from this table also. So we'll discuss the question which was asked, and also in recent other exam, some other exam they have asked a very simple question: which of the following is a cause of cortical dementia? Simple. So such direct questions, because they are asking, so such question may be asked from this topic. Okay. So from the name itself, you can say, so it is basically based on the site of lesion. Cortical dementia and subcortical dementia. So from the name itself, isn't it, we can see in cortical dementia, what is affected? The cortex, the cortical lobes are affected, right? So the frontal, temporal, parietal, occipital, these are the cortical regions are affected, right? While what is affected in subcortical dementia? The subcortical gray matter, like thalamus, basal ganglia. So these areas are affected. Okay. From the name only you can see subcortically, right? Now, can you tell me certain examples of cortical dementia? Can anybody tell me? Very good. Alzheimer's disease. Any other? We have just discussed that. Very good. From the name itself, what is the name of Pick's disease? Frontotemporal dementia. Name is only telling. Frontal and temporal lobes are affected, right? So, frontotemporal dementia. This was the question which was asked. They had asked which of the following is a cortical dementia, and one of the options was frontotemporal dementia. Okay, so it was written FTD. FTD again is in one place. FTD means formal thought disorder. Here FTD means frontotemporal dementia, right? Okay. Then certain examples. Can anybody give me any examples of subcortical dementia? Very good. Huntington's disease. What is this disease? Parkinson's disease. Parkinson's disease. Then Wilson's disease. Multiple sclerosis. Okay. Okay, so these are some. Now, if I ask you, where have you read all these diseases? No, in these, good, yes, pathology, definitely. Where when you read these diseases in medicine, what are the important symptoms you come across? Any of these? You come across motor abnormalities. You don't talk about dementia in these cases. Although we know, yes, Huntington's chorea, Parkinson's, there is rigidity, there is tremors, there is bradykinesia. Wilson's, again, there are motor manifestation. Multiple sclerosis, again, many motor manifestations. So most of the time we talk about them in movement disorders, but they also have dementia. Okay, why? Now let's discuss the third point, then I'll explain you. So if I ask you, motor symptoms or the motor system is normal in cortical dementia, abnormal in subcortical. So you will get motor symptoms like there may be tremors, there may be rigidity, there may be chorea. Okay, so any motor abnormality can occur. Okay, so basically, please understand, when I am saying that cortical dementia cortex is affected, I am not saying that subcortical region is not affected. What I am trying to say is, initially in cortical dementia, the cortex is involved. Later on, even the subcortical regions may get involved. Similarly, in subcortical, initially subcortical, over the course of time when the disease progresses, even the cortex is involved. So I'm talking about initial presentation. So in cortical dementia, initial presentation is more of cognitive impairment, while in subcortical dementia, initial presentation is more of motor. Why? Because the subcortical region is affected. The basal ganglia, basal ganglia is associated with movements, isn't it? So this is how clinically we can differentiate. If a patient has more of motor symptoms initially, that means patient is more likely to have subcortical dementia. Okay. Again, such question may be framed. Okay. Then there are certain other causes like vascular dementia. Okay. Lewy body dementia. LBD is Lewy body dementia. These can occur both. They can occur as cortical or subcortical from the beginning. Okay, so vascular and Lewy body dementia, LBD, can occur as both cortical or subcortical. Vascular event can occur in any part of the brain. Okay, so these can occur in both ways. Okay. Yes, it can progress. Okay, over the course of time, we have seen patient do develop other symptoms also. Okay. So this is again very important, especially the examples. Please remember, very simple questions have been framed from this topic. So this is very, very important, right? Pathology has been done? Patho? Okay. So everyone has written this? Everyone has written this? Lewy body dementia. I'll come to that. LBD is Lewy body dementia. Right? You want to break?
Yes, sir.
Let's start at 5:30.
Sir, 5:30.
So I hope I'm audible. Yeah. Yes, sir.
I'm not saying कि
नहीं,
आगे पीछे करो जो भी है उसके बाद
dementia. So as I told you that everything is important. In this small table, question was asked. So you don't know from where they will give you a question, but please understand they are giving question from the notes only. Okay. So I will discuss. So most of the question are from the notes. It's just that we have to be thorough. That is why we are taking some time. If I just given you one or two calls, the actual question would have been lost, isn't it? So this is how they are asking question. So they will this may appear like a biochemistry question or a medicine question, but you have already discussed this in psychiatry, right? And again, same goes with this. This question has been asked previously. Frontotemporal dementia. They asked which of the following is not a subcortical dementia. Option was, they had not given Alzheimer, but the option was frontotemporal dementia. Name was only telling you the cortex is involved. Frontotemporal dementia, right? Let's discuss these disorders one by one. One is dementia of Alzheimer's type, or that is Alzheimer's dementia. Okay. Types of dementia. Now we are discussing various types of dementias individually. Okay. So basically, again, it's a cortical dementia. Again, if you ask me in the cortical dementia, which lobes are more commonly affected? It is a parieto and very good temporal distribution. Okay. So parieto-temporal distribution. Right. Now, please understand the dementia of Alzheimer type or Alzheimer's dementia is a slowly progressing condition. Slowly progressing. So, many times when the patient comes to us, okay, so the disease starts very slowly. So sometimes, the patient when is brought to us, it is 2 years, 3 years have already passed. Okay, so at that time, it is in fact the entire cortex may be affected. But if you are able to catch it early, you will see that parietal and temporal lobes are more affected initially. So for example, if you get a CT done in the initial stages, you will find more changes in the parietal and the temporal lobe. But of course, when the patient is brought to you, it's a slowly growing disease. Most of the cortex is affected. So you will see entire lobe is entire cortex is affected. Okay. But if you have to choose which lobes are affected, it is parieto-temporal distribution. Now tell me, it is more common in males or females? How many if you say males? How many if you say males? How many if you say females? It is more commonly in females than males. Much more common in females than males, right? Okay. Now again, you've discussed this in medicine is done, pathology is done.
Yes.
We've discussed some genetics about it. Okay. We discussed about the genetics. Have you discussed about the genetics? Genetics of dementia has been discussed. So basically, I'll just give you I'll just explain you a few things. So in genetics, as I told you, it can be early onset or it can be late onset. Again, there are certain genes which have been identified. Okay, so especially for both, we know even for early onset, most common cause is Alzheimer's, right? So for early onset ADs, Alzheimer's dementia, there are 3 important genes which have been identified. Okay, first is amyloid precursor protein or the APP. Amyloid precursor protein or the APP. Can anybody tell me which chromosome this is located? Trisomy? Any trisomy you know? Trisomy Downs is trisomy 21. This is also seen in chromosome 21. In fact, many a times patient with Down syndrome also develop early onset dementia. So a person with Down syndrome may develop dementia at the age of 30 years. And many a times the cause is this gene, APPG. Okay. So it is on chromosome 21, right? At least remember this. Okay, again, you may be given a patient with Down syndrome, they may be given features of Down syndrome, and ultimately they may ask you, he's having dementia, which of the following gene may be associated. Okay, so it may be such integrated question may be asked. Okay, next is presenilin 1 or PS1. Okay, presenilin 1 or PS1. Okay, and then it is presenilin 2 or PS2, PlayStation 1, PlayStation 2, right? You can remember like this. Okay, then in late onset, many genes have been identified, many genes. But one very important gene which I want you to remember is apolipoprotein E4 or apoepsilon 4, ApoE4. It is apolipoprotein E. Okay. So these are important genes. These are important genes which have been identified. Of course, there are many other genes. These are some of the common genes. Okay. Do you remember them? You may be asked which of the following gene is not implicated in Alzheimer's disease. Okay. So you should know what are important genes which are implicated, right? Now, so write it down. Just for the online students, am I audible? I hope the voice is audible for the online students. So let me know in the chat box if I'm audible. Yes, great. Okay, so this is early onset and late onset Alzheimer's, right? Now, next is, again, we'll just try to understand, few things. We'll try to integrate. So pathology wise, if I ask you, what will you do, what will you see macroscopically? That is, suppose you do a post-mortem, you take out the brain. What will you see? It will not be empty, but what will be there? Atrophy. There will be shrinkage. Or suppose person is living, you do a MRI scan. What will you find? You will find there is shrinking of the cortex. There is atrophy. So you will find atrophy of the brain. Okay, you will find atrophy. Okay. Which initially, if you are able to catch, which lobes will be more affected initially? Very good. Parieto-temporal. Suppose you cut a slide from the brain and you put it under the microscope. What findings will you find in microscopically? Yes. What kind of plaques? Amyloid plaques. These are also known as very good senile or neuritic plaques. Okay, also known as amyloid plaques. These are also known as amyloid or senile or neuritic plaques. Now tell me, these are intracellular or extracellular? These are extracellular. Okay. Around the cell you will find the accumulation of these plaques. Second, any other thing which you may find starts with N. Any tangles? Neuro, very good. Neurofibrillary tangles. Okay. These are intracellular or extracellular? These are intracellular. Right? So we will find these changes again. Such questions may be asked. Now, this question was asked. Now, we always discuss this, and this, I'll show the slide. Everyone has written? Right. So this was the question in June 2021. We always discuss this and this simple question was asked. Okay. The question was, what are the changes, neurotransmitter changes in dementia? Okay. Now, so what is the neurochemical changes, neurotransmitter? Which neurotransmitter is affected? Which was very good. There is a decrease in acetylcholine, right? And also one more neurotransmitter may be implicated. There is a very good. There is an increase in glutamate. Now also remember this concept because this will also help in the treatment. When I talk about treatment, what we need to do? We need to increase acetylcholine. We need to decrease glutamate. So this will also be helpful. So many times the mechanism of the drugs you are able to remember, because of the problems which occur in the disease. Okay, so we'll come to the treatment part shortly, right? So this was about Alzheimer's. Second type is vascular dementia. Second is vascular dementia. Okay, I'll just show the last slide. Just see the slide again if you missed anything. Okay. If you just missed anything, just see. Okay. So this is very, very important. Please mark hashtag over this. This was a recent question. So look, just question from such a small topic they've asked. Okay. So this is how they're trying to integrate things. Okay. So this is how they're trying to integrate things. Now next is vascular dementia, or also known as multi-infarct dementia. Okay. So vascular dementia, or also known as multi-infarct dementia. So basically why it is called vascular dementia? Because there is some vascular injury. Okay, so there is stroke, there is some, there is some rupture of vessel. So there is certain area of the brain is affected. There may be infarct. Okay, so there is ischemia, less blood supply to any specific area. So because of vascular injury, vascular insult, patient develops this dementia. So you will find that these generally will have more acute onset, more sudden onset. Suddenly the event occurred, suddenly the stroke occurred, and after some time you will find. So as compared to Alzheimer's, it is more of acute. Okay, symptoms will develop suddenly. Okay, so it has more of sudden in onset. Symptoms may occur more suddenly than Alzheimer's, right? Now tell me, it is more common in males or females? How many of you say males? How many of you say females? Okay. Now please understand, vascular events, who is more at risk? Males or females? So it is more common in, yes, males. Okay. So risk factors may include history of hypertension, diabetes, hyperlipidemia. Okay, increased lipid. Then history of alcohol consumption, history of use of tobacco or nicotine. Okay, so all these are certain important risks. So you may get a 40-year-old male who is having chronic hypertension, smokes cigarette, consumes alcohol. This, they may be asking about vascular. Okay, right? So these are important risk factors. Now one point about vascular dementia I want you to remember is its presentation, or what is the pattern of vascular dementia. It has a unique pattern known as step ladder pattern. Step ladder fever is seen in typhoid. Very good. Step ladder pattern of the symptoms is seen in vascular dementia. What is step ladder pattern? Basically, let us say the patient developed at the age of 30 years, he had a stroke. Okay, so there was a vascular event, stroke occurred, he developed symptoms. After some time, the symptoms came to plateau. Okay, the symptoms came to a plateau, right? Let us say again after, at the age of 40 years, he developed another event, another vascular event occurred, another stroke occurred. He again developed symptoms, and the symptoms after some time again came to plateau, right? Let us say again at the age of 50 years, he developed another stroke, he developed suddenly symptoms developed. After some time he developed, the symptoms came to plateau. So this is what is known as step ladder pattern. Okay, so this is what is known as step ladder pattern. The symptoms would increase with time, like this. Okay, so this is again very important. Step ladder pattern seen in vascular dementia, very important, right? Okay, now next is, everyone has written this? Okay, frontotemporal dementia. What is the other name of frontotemporal dementia? Very good, Pick's disease. It is the second most common cause of early onset dementia, right? So this basically occurs at early age. In 40s and 50s, you may find patients with frontotemporal dementia. So what is happening in frontotemporal dementia? There is atrophy of the frontal and the temporal lobes. Okay. So there is atrophy of the frontal and the temporal lobes. Okay. Now, there are two forms of frontotemporal dementia. Okay, again, I'll try to correlate, again, it's not given in books, but let's try to correlate so that we are able to solve MCQs. Yeah. This, right. Okay, so we are basically talking about frontotemporal dementia, also known as Pick's disease. It's a cortical type of dementia. It is the second most common cause of early onset dementia, right? Lobes which are more commonly involved are frontal and the temporal lobe. Okay, right. Now it has two forms. There are two variants or two forms of FTD. One is the behavioral variant. Second is the language variant. Two forms of FTD are seen. There are two forms. Behavioral variant. Again, just let's try to correlate. Tell me, if behavioral symptoms are there, which lobe is more likely to be involved? Frontal lobe. So here, basically, because of the involvement of frontal lobe, you may find predominant behavioral symptoms. What kind of behavioral symptom? This is very, very important. They may not ask you this as corresponding to frontal temporal dementia, but this may be asked as a very individual question. What changes may be there when a person's frontal lobe is affected? There was a very good question about frontal lobe. I'll discuss the here only. So let us discuss. So patient may have personality changes. Okay. In the past, there was a case, very famous case. Okay, that person, what happened, that there was an iron rod which just went through his brain in the frontal lobe. There was an iron rod which went through his, he was operated, it was removed, he survived, but there were changes in his personality. Okay, so which lobe may be affected? It is the frontal lobe. Okay, second is very important is there are certain behaviors which we inhibit ourselves from doing. Okay, for example, if you have to, if someone has to go to the washroom, the person will go in the washroom and use it. Okay, and again you are sitting in the class, you will not, start dancing here. Now, of course, when you are on a marriage on the street, you are dancing. That is very normal. But there are certain behaviors which we inhibit ourselves from doing, right? But when frontal lobe is involved, patient develops certain disinhibitory behaviors. Disinhibitory behaviors. Okay. So there are certain inhibitions. When frontal lobe is affected, those inhibitions are lost. Patient becomes disinhibitory. So there was a question which was asked that a person goes on the roadside in public, he urinates and he does not have any guilt of doing so. Which lobe is likely to be affected? Frontal lobe. This is disinhibitory behavior. We would inhibit doing such behavior in public, but he is doing it. So there is disinhibition. So this question has been asked. So there may be disinhibitory behavior. Of course, again, frontal lobe regulates which? Regulates what it regulates? Frontal emotions. So emotional problems will also be seen. Okay, emotional disturbances may also be seen. So this is very, very important. The disinhibitory behavior, this question has been asked individually also. Okay, and even in the behavioral variant of FTD also you may find these behavioral problems, right? So this is behavioral variant. Second, language is controlled by which lobe predominantly? Temporal lobe. So again in the language variant we will find problems in language. For example, word understanding is not there, grammatical problems are there. Okay, so language impairment is there. Language impairment, if there is predominant language impairment, then it may be the language variant of the frontotemporal dementia, right? So again, this was about frontotemporal dementia. If I ask you in pathology, what you will find microscopically, which bodies you will find? Pick bodies are there. That is why it is known as Pick's disease. Okay. Now, next is, this is very, very important. Put hashtag of this. This is very, very important. Very important type of dementia. Now we know, our understanding about it is increasing. We know the prevalence is also increasing, right? Disinhibitory. There are certain behaviors which I would inhibit myself from doing. Suppose I feel like dancing, I'll not start dancing here. I'll inhibit myself. But when the frontal lobe is affected, those inhibitions are lost. So you will tend to do certain behaviors which usually you will inhibit yourself from doing. Okay, so this is disinhibitory behavior. Okay. Very commonly micturating in public. This is very common question which is given in disinhibitory behavior. Now this, put double hashtag, this is very, very important topic. You may get a question from this. This is very important. Dementia of Lewy body, or you can say Lewy body dementia, right? Lewy body dementia. Okay, Lewy body dementia, right? Now, there are three core features. Okay, this was step ladder pattern is that the symptoms are increasing with time in that manner. So let me just show you the slide. So like this, at 30 years, symptoms developed, came to plateau. At 40 years, another stroke occurred, symptoms suddenly developed, then came to plateau. Again, at 50 years, symptoms again increased, came to plateau. This is step ladder pattern, right? Okay, so we're discussing Lewy body dementia. Don't worry if there is any slide you have missed. I'll show the slide in the end again. Now, core features, three core features you should remember. One is there is fluctuating cognition or fluctuating cognition impairment. So cognitive impairment is there, but it is fluctuating. It is going, so family members will say, doctor, morning attention was less affected, by afternoon it was more affected, then again less affected. So there is fluctuations in cognitive impairment. Second point, very, very important, is visual hallucination. Now you can see, even in the core criteria, we have kept visual hallucination as a clinical feature. Remember when I talked about visual hallucination, I told you they're more common in organic mental disorder. I've told you in delirium also you may find visual hallucination. Even in dementia, especially one dementia, it is in the core criteria. So patient will say he's seeing things like he's seeing someone very clearly. In detail he will explain. So visual hallucination may be seen. Very, very important. This is a very important type of dementia. Be very thorough with this. Third is motor features of Parkinsonism. What are the motor features of Parkinsonism? Tremors. Very good. Rigidity. Bradykinesia. Okay. So all these motor features of Parkinson are also seen. So let us say, they may give you a question. A 70-year-old male has problem in language, has problem in attention. He's saying that he's seeing things which no one else is able to see, and he's also having tremors. Diagnosis. He's having cognitive impairment, he's having visual hallucination, he's having features of motor features of Parkinsonism altogether. This is Lewy body dementia. Very, very important. So please understand, they will not give you direct statements. They will give you symptoms. You have to see what symptoms are there. So this is very, very important. Please remember this. I have specially highlighted this. So this is because very, very important. Okay. There are also some suggestive features. Suggestive features means that if patient has these symptoms, it is likely that he is having Lewy body dementia. One very important feature which I want you to remember is that they are sensitive to antipsychotic induced extra pyramidal symptoms. Okay, right? So they are basically sensitive to. Now please understand, there is a person who is having visual hallucination, psychotic symptom. You may tend to start antipsychotic. Let us say we started antipsychotic. Suddenly, this patient develops severe contraction of the neck on one side. Severe contraction of the neck. He is not able to move the neck. He is very agitated. He is very fearful. What is this? There is sudden contraction. These are motor side effects which can be produced by antipsychotics. These are known as extrapyramidal symptoms or EPS. Okay, like this was acute dystonia. This was like dystonia. So basically antipsychotics can produce certain motor side effects. So these patients are very sensitive to these side effects. Okay, so some patients, normally I start a patient on, let us say, olanzapine. They may not develop this, but these patients are prone to develop these side effects. Okay, so this is very important, again, important suggestive feature. Please understand, I am not saying that you should not give antipsychotics. If you feel that antipsychotic is required, start with low dose. Give low dose because they are sensitive to the motor side effects produced by antipsychotics. Okay, so this is a suggestive feature. If patient has developed this is suggesting possibly patient is having Lewy body dementia. Okay, pathology wise, if you see, you do a section, put it under microscope, what will you find? The name is, what is the name? Lewy body. You will find Lewy bodies. Right, so you will find Lewy bodies in microscopic section. Okay, so again I'll show the entire Lewy body dementia. So this is very, very important. Okay, so this slide is very important. Please remember this, and again try to see in the question what symptom they are giving you. Okay, and then see what is the answer. Okay, so these were some important types of dementias. Now, Huntington's, again, you don't have to write, we have already discussed Huntington's, Parkinson, Wilson's, these are all subcortical. More about this you will study in your medicine, right? But please remember, dementia is also seen here. Okay, they are also dementia, they are causes of subcortical dementia, right? Now, also HIV related dementia is also seen, also known as AIDS dementia. So, HIV dementia or AIDS dementia. Now, please understand, I told you that infections, many infections are reversible cause of dementia, but this particular infection is a progressive condition. It is progressive. It is progressive. Ultimately, patient may also die. Okay, patient may die. Okay, so it's a progressive condition. This one, especially particular infection, it is progressive. Now, if I ask you, remember I told you Lewy body dementia can be both cortical and subcortical. So in the core criteria, you can see there are some cognitive features also there, cognitive impairment, and motor symptoms are also there. So both may be affected, right? Okay, so this is HIV related dementia known as AIDS dementia. It's a progressive condition. Again, you may also find motor changes are there, personality changes may be there. So it's a progressive condition. Last is head trauma related dementia. trauma related to dementia related to head trauma. This is also known as dementia. Anyone? Very good. Dementia pugilistica. Can anybody tell me where you may find this? In which profession? Very good. You may find this in boxers. So what happens in boxing? Patient, they have multiple minor injuries. Over the course of time, these injuries increase. Okay. So, again, people consume alcohol in drunk state, they may. Right. So this was about the types of dementia. Two types of questions you should be very careful with dementia. One is clinical presentation. Second is treatment. In delirium, treatment was not that specific, but dementia we have very specific treatment. These questions 2018, 2019 back to back question on this has been asked. Okay, so let's come to the management. Let's come. Write it down. Let's write it down. Everyone has written this? Right. So let's come to the management. Now there is one important scale which we use, okay, that is known as mini mental punch drunk syndrome. Drunk. In drunk state, people punch, head injury leading to dementia. Okay. Now one is, so in the management, so there is one very important useful instrument. Instrument means it's basically a questionnaire. There are certain questions we ask from the patient, we give some task to perform and we get a score. This is known as mini mental status examination, MMSC. We get a score. So total score in MMSC is 30. Okay. So the total score is 30. A score of less than 24. So total score is 30. A score of less than 24 is highly suggestive of, SO is suggestive of dementia. It's not that we will be confirmed, but this is highly suggestive. It is highly suggesting that the person is having dementia. So a low score in MMSE is suggestive of dementia. Okay. This scale was given by Falstein et al. Falstein et al. Et al means other people were also there. Falstein et al. Okay. So they gave this scale MMSE, very common scale, very commonly used. Okay. Now, if we come to the treatment in the management, first and very important is you have to treat the cause, isn't it? So because we have discussed that there are certain reversible causes, isn't it? I've talked about, so if suppose there is vitamin B12 deficiency, treat the deficiency. Hypothyroidism, treat the hypothyroidism. Hemorrhage, treat hemorrhage. Patient will improve. Always try to find out any reversible cause. Very, very important. Second is there are certain drugs. One important group of drug is cholinesterase inhibitors. So basically these are inhibitor of enzyme acetylcholinesterase. So basically this enzyme, what does it do is, this enzymes basically break down acetylcholine into acetyl and choline part. So this enzyme basically what it does is, it breaks down acetylcholine into acetyl and choline part. Okay. What was the change which was occurring in dementia related to acetylcholine? Decrease. So if I inhibit this enzyme, what will happen? There will be increase in acetylcholine, right? So we are doing this. This was the, again, very important. This question was asked that there is a decrease in acetylcholine dementia. I've already discussed. Now, so let us discuss some important drugs. Yes. So there are important drugs like donepezil, very good, rivastigmine, Anyone, any other drug starting with G? Galantamine, very good. Galantamine. Okay, so these are very common drugs we use very commonly. Donepezil, rivastigmine, very common drugs we use day to day in the patient when we see of dementia. There was one more drug, Tacrin. Very good. This drug has been banned. Why it is so again? So we are also discussing certain pharmacology aspects. Okay, so a lot of your pharmacology will also be covered. Okay, especially your neuropsychiatry. It is banned because of hepatotoxicity. It is hepatotoxic. Okay, please remember this. Okay, so these are the question which was asked was a very direct question in 2019. What is the treatment of Alzheimer's disease? One of the options was donepezil. The answer was straightforward. It was donepezil, right? So this is one group of drug we use. Now tell me, what was the other problem which was there in dementia? What other neurotransmitter was implicated? Glutamate. What was happening in glutamate? There was an increase in glutamate. Please understand, glutamate is neurotoxic. Okay, glutamate is neurotoxic. Excessive glutamate leads to neuronal damage. That is why it was leading to dementia. So what we can do is we can use one drug which is known as mementin. What is the mechanism of action of mementin? It is very good. It is a NMDA antagonist. NMDA antagonist, very, very important. NMDA is a glutamate receptor. It's a glutamate receptor. Okay, so basically it is antagonizing a glutamate receptor. So this is again a very, put a hashtag over this. This question they have up till now not asked. So they have asked a lot of questions related to donepezil. They have not asked question related to mementin. So this may be a new question which you may get, because this drug is there in the market for a long time now. Relatively new, but we have been using this drug for quite some time, right? There is a recently newer drug. There is a new drug in 2021. A new drug has been developed. Now this is a drug which is now this is the first drug for dementia which is specific to the cause. First drug. This is aducanumab. From the name you can get, it is a human. Yes, very good. IgG1 monoclonal. MAB is monoclonal antibody. What it does is it basically binds to the A beta aggregates. Okay, so beta proteins. Okay, so the amyloid protein, beta amyloid proteins, that leads to these aggregates. So it targets these aggregates. So it's specific to the cause. So earlier we were just symptomatically improving. This is the first drug we have got that is treating the cause. So it's a very again, this drug has been approved by FDA, but what they're saying is let's also do a post market surveillance, because they are in a hurry, they have approved this drug, so now they are also following up how the patients are responding. But in the trials, this drug has shown to be very effective. So this is a new drug. So you can remember AD is Alzheimer's disease. So from the name itself, AD means Alzheimer's disease. It is a drug which is approved for Alzheimer's disease, particularly Alzheimer's disease, because there we are getting these aggregates. Okay, so it is targeting and this is breaking down these aggregates. Okay, so this is very important. So it is the only approved targeted therapy, and it is given as a IV injection. Okay, so basically given as a once a month IV infection. This is a new drug, and because of the mechanism and because of it is the only approved targeted therapy, you may get this question. Although it's a very new, but again, you may get this question as a pharma question. Okay, so this is very, very important. Nowadays, a lot of monoclonal or antibody questions have been asked. So from even psychiatry, you may get this question. Okay, so please remember aducanumab. Okay, Everyone has written. This is very, very important. Right. Now, so other than this, so these were the treatment. Of course, we also know that there are behavioral symptoms also, right? So patient may also have some behavioral symptoms. Okay. So if patient is having depression, anxiety, you can start antidepressants. If patient has some psychotic symptoms, delusions, hallucination, agitation, you may use antipsychotics. Patient has insomnia, you may use benzodiazepine. This was the question which I was telling you about. So one of the question was in which of the condition you do not use antipsychotics. Okay. So one of the option was dementia. Do we use antipsychotics in dementia?
Yes.
Off-label use we can use based on the symptoms which are produced. Okay. So please remember this. Sometimes we use antipsychotics, low doses generally, right? Okay. So this was about, so in the treatment of dementia, please remember the drugs. Okay, these are very, very important. Every time they are asking question, the question which were asked in dementia was very, based on the causes. Vitamin B12 question was there, acetylcholine question was there, 2021. Now, the last is organic amnestic syndrome. Just remember 1 or 2 points about this. Okay, so this is not very important topic, but still I just to cover the list. Now tell me, so let's go one by one. Delirium, what was happening? Consciousness was impaired, cognition was also impaired. Everyone clear? Let's come to dementia. In dementia, what was affected? Only cognition. In organic amnestic syndrome, even in the cognition, we discuss various parts of cognition, only memory is affected. So this is how you can remember. The name itself is telling us it is an amnestic disorder. Amnestic means only amnesia, only memory loss. Other cognitive functions are not affected. Okay, so basically what is affected? Memory impairment is affected. Okay, especially recent memory and remote memory. Okay, especially recent and remote memory. Okay, so only these are affected. Other things are not affected. Okay, recent and remote memory, right? Now, so what all things are intact? Immediate memory is intact. Okay, consciousness is intact, because if consciousness is impaired, what will be the diagnosis? If consciousness is impaired, what will be the diagnosis? Yes, it will be delirium. Okay, so we are saying we have to rule out. So we have to see also that other symptoms are not affected. And the last you can say other cognitive symptoms are also intact other than memory loss. Other cognitive symptoms. If other cognitive symptoms are also affected, impaired, then what will be the diagnosis? It will change to dementia, right? Because dementia, 2 or more cognitive impaired. One is memory was already affected, and let us say another one is affected. We say it is dementia. So only memory is affected. Yes. No, only Recent means 24 hours. Past 24 hours, a few days. Remote is past few months. The immediate memory, that is not affected much. Okay, it remains intact. Okay, so this is organic. So why I am discussing organic amnestic syndrome here with you? There is one important condition I want you to remember. Now, there are many causes. Don't write all the causes. Just remember there are CNS causes. Any CNS cause, trauma, tumor, infection, you can think of can cause it. And in systemic cause, this one cause, please don't write entire thing. Okay, don't write everything. Okay, don't write everything. Just write there can be CNS causes, there can be systemic causes. In systemic causes, I want you to remember one. Alcohol, chronic use of alcohol can lead to an organic amnestic syndrome. Alcohol-induced organic amnestic syndrome is known as Korsakoff syndrome. Very, very important. Question in 2020 that asked about, cause, what is the cause of Korsakoff syndrome? Can anybody tell me? Alcohol. Why in alcohol you find Korsakoff syndrome? Deficiency of which? thiamine, B1. This was the question. So, such simple questions have been asked. I'll come to that question. This was a December 2020 question. Okay, so Korsakoff syndrome, I'll talk about. So when I'll talk about Korsakoff syndrome, I'll tell you there is amnesia. You will be able to remember because it is, we have read it in organic amnestic syndrome. This one point I want you to remember, right? So even in separate thiamine deficiency also it can occur. There may be many other causes. This one cause in particular I want you to remember. Okay, don't write all these causes. So write, just write, this one. This is very important. Okay. Yeah, please write it. Don't worry. Take your time. Write it. Okay. So dementia, delirium. Please be thorough. When you know the concept, revising hardly will take 20 minutes. Okay, but it will fetch you 2 to 3 questions from this topic. And please believe me, they are asking questions. I will talk about the MCQs in the end. You will see that many questions from these topics have been asked. Okay, so 2-3 questions matter. Sometimes you are stuck on 149. You will feel that one question I would have known. So one question also matters a lot. Okay, and in short time you will be able to solve many MCQs in psychiatry, right? So again, be positive. Yeah, right. Okay. So always be positive. This is one funda which I always say. Because there will be so many people which will talk about negative thing. Oh my God, Afghanistan. What is happening in Taliban? Okay. Today, if India loses the match, oh my God, India has lost the match. So there is so much negativity which is occurring around. But if you are positive, you are ignoring the negativity. This very simple concept is there. Our brain, whatever you feed our brain, you will get that plant. If you are feeding the plant of positivity, you will get a plant of positivity. And if you are feeding negativity to your mind, you will get a plant of negativity. So the mind never says no. Whatever you wish, you will get it. So try to be positive. Try to be with people who are positive, and things will become very easy, especially in our profession. This is very important, especially in our profession. And it's a very noble profession. COVID, health profession has been one of the most important. The religious places were locked. The food chains were locked. Everything was locked. The only thing which was open was hospitals. Okay, so it's a very noble profession we are in. Of course, there are certain incidences which put our morale down, but they are again just small things. When you get that feeling of treating the patient, you love this profession even more, right? So this was about organic mental disorders. Let us discuss one very important topic. Let us discuss certain psychotic disorders. Okay, so we are going to discuss schizophrenia and other psychotic disorders. We are discussing now new topic. Okay, new topic we are discussing, right? So in the psychotic disorder, the first important disorder which we are going to discuss is schizophrenia. Now we have discussed so many times schizophrenia. Let us now deal with schizophrenia. Okay, let us see what is schizophrenia. Now, in schizophrenia, history is very important. So there were many gentlemen. Now please understand, our understanding of schizophrenia which we right now have has developed over the course of time. In the 1800s, people did not know schizophrenia the way we know now. Okay, understanding of schizophrenia has developed over time. Okay, some gentlemen give some, some definition, some gave some. Eventually, we now know what is schizophrenia. This is a current understanding. So let us understand the historical perspective. One gentleman was Emil Kraepelin. So there was one gentleman, Emil Kraepelin. He gave the term. So he saw certain patients, and he termed them that they have dementia precox. Again, it's an MCQ which has been asked previously. Term dementia precox was given by Emil Kraepelin. This is a very important question, has been asked previously. So now when we see his description, his patients, so he has described his patient. Now when we see those descriptions, we see that those were patients who were having schizophrenia. So that means he tried to understand schizophrenia. At that time, it was not called schizophrenia. He gave the term dementia precox. What is the meaning? Dementia, we know it is cognitive impairment, cognitive decline. He said that there are certain patients who are showing such decline at a younger age. Okay, at an early age. So he said they have, so precox means early onset. Please remember, I am not saying they are having dementia. It was his understanding. He said at his time dementia was known. He said there are some patients who are showing such features at a young age. He called them as dementia precox. Right? So this is an important question which has been asked. Second came another gentleman, Eugene Bloiler or Bloiler. Simply you can remember Bloiler. Eugene Bloiler. Very important person. Eugene Bloiler. Okay. He was the person who coined the term schizophrenia. Okay. So he was the person who gave the term schizophrenia. Schizo means split. Phrenia means mind. So he said that these patients have a split in their mind. What he meant was that there is a split between thought and emotion. He said that whatever, so patient would say, whatever I am thinking, my emotions are not corresponding with it. So patient would have split in their, split between what they are thinking and how their emotions. So please understand that was his way of understanding. Okay, now we know what is schizophrenia, we'll discuss about it. This was his understanding. Okay, please remember this, schizophrenia is not split personality. In general population, people, consider split personality with schizophrenia, but we should know, we as doctors should know, schizophrenia is not split personality. Split personality is a dissociative disorder. Multiple personality disorder, will come to that later on. Okay. Schizophrenia is not split personality. Very important. Okay. So one thing which Bloiler gave was he coined the term schizophrenia. Now since he had coined the term, you also need to define it. What do you mean by schizophrenia? So he said he gave 4 symptoms which are known as Bloiler's 4 A's. Okay, so he gave 4 symptoms. He said, so I call schizophrenia when the person is having these symptoms. Okay, so again, this has been previously asked as an MCQ. Which of the following is not in Bloiler's 4A symptoms? Okay, so again, many of these symptoms we have discussed. Loosening of association. We have discussed this. This is a disorder of underthought. Which part of thought? Flow, content, form, possession. Flow, no. Form, very good. Form. Remember disorganization, loosening of association. Remember disorganization, C, B, it was not organized. Remember? I told you very commonly you may find it in schizophrenia. Again, this is also we have discussed affective flattening or flat affect. Have we discussed this before? In affect, what is flat affect? When there is no change in emotion. Remember I told you seen in schizophrenia. So this was second symptom. Third is autism. So please remember this is not the autism which we will discuss in child psychiatry. Autism basically means self-absorbed. He said that these patients live in a fantasy world. So he called them, they have autism. They have fantasy thinking. So they live in a fantasy world according to him. So he gave the symptom that there is autism seen. Okay, so there is autism, right? And the last symptom is ambivalence. Last symptom is ambivalence. What is ambivalence? Ambivalence is inability. It is inability to take decision. You may, read it, ambivalence, when you're confused, you're not able to take a decision. We say the person is ambivalent, is not able to take the decision. So this is ambivalence. For example, let us say there is pen on the table and the patient is confused. He's just split. He does not know whether I should pick this pen or I should not pick this pen. So he's thinking whether I should pick this pen or I should not pick this pen. This is occurring at the level of thought. He's not able to decide at the thought level. Whether so he's just seeing, you will see he's just staring the pen. But in his mind, he's getting this thought whether I should pick this pen or whether I should not pick this pen. Okay, so this is ambivalence, right? This is ambivalence. So these are the Bloiler's 4A symptoms. Again, this slide is very important. Bloiler two important major contributions in schizophrenia, very, very important contributions of Breuer. The term schizophrenia was given by Breuer. Then there come another gentleman. He said, okay, let me burden the students more. Let me burden them more. But he is the last gentleman. He's the last gentleman. So that was Kurt Schneider. Okay. So he said, okay, since someone has coined the term schizophrenia, let me try to give symptoms on my own. He gave 11 symptoms. 6 symptoms we already have discussed. So we will just write them. Okay. 6 symptoms we have already discussed. So this is what is known as Schneiderian or Schneider's first rank symptoms. SFRS. First rank means primary symptoms. He said these are the important symptoms of schizophrenia. Okay. Schneiderian or Schneider's first rank symptoms or the SFRS. Okay. So SFRS. Okay. So first, let us look at the first 3 symptoms. One is audible thoughts or thought echo. Doctor, I am able to hear my own thoughts. What is this? Auditory hallucination. What? First person. Very good. Second is voices arguing or discussing about the patient. What is this? Voices are discussing amongst themselves about the patient. Third person. Right? And next is voices commenting on one's action or giving a running commentary. Again, this is also third person. So remember I told you, I will tell you again in schizophrenia. So first is first person auditory hallucination. The next 2 are third person auditory hallucination. So all these are basically auditory hallucinations. So if someone asks you, auditory hallucination is a symptom of SFRS. Is it true or false? Is it true? Is second person auditory hallucination there?
No.
False.
It's not totally true statement. Not all the hallucinations are included. Only these 3 particular hallucinations are included in SFRS. Have you understood this point? All hallucinations are not there. Only in auditory, these 3 specific ones are included. Right? Now, next is, everyone is clear? Next is, again we have discussed this, thought withdrawal, thought insertion, thought broadcast. Where have we discussed these? These are thought, doctor, someone is inserting the thoughts, someone is withdrawing my thoughts are getting broadcast. Disorder of flow, form, content, possession. Which type? Thought alienation phenomena or passivity of thought. Thought alienation. So now we don't have to discuss them again. This is thought alienation phenomena. Okay. So the first 6 we have already discussed. Now why I am telling you this is important is because there are many questions. They may ask you which of the following is not SFRS. Okay, so you should know. History of schizophrenia is only relevant. Rest of the disorders history is not that important. Okay, so that is why we are discussing schizophrenia. Okay, so everyone is clear with the first 6, right? Now let us discuss the next 3. So these are basically made phenomena. Let's write them first, then I'll explain what it is. Okay, so these are made phenomena. I'll tell you what is it. Let's write them first. It is made impulse, made feelings or affect, made acts. You can remember it with the mnemonic IFA. There are IFA awards in Bollywood. Okay, IFA awards are there. So you can remember by IFA. Made impulses, made feelings, made acts. Okay. So what happened? Made. What is the meaning of made? Someone is making me do something. It is not mine. So patient experience, patient says that patient's impulses, his feelings, or his actions or his acts are basically are influenced by others. So patient may say, doctor, you're seeing the OPD ward patients. One patient is crying. You go and ask the patient, why are you crying? The patient may say, doctor, I'm looking like I'm crying, but this is not my emotion. Someone is making me cry. So this is made feelings. That this is not my feeling. Someone is making me feel like this. Another example, patient may say, doctor, I'm getting this repeated urge or impulse to stand up. But doctor, this impulse is not mine. Someone else is making me have this impulse. Now, again, another example. There was a patient, he slapped another patient. You went to him and said, why you did this? That patient may say, doctor, I did not do this. Someone influenced me to do this. So this is made act. Okay. So impulses, feelings or acts are influenced by someone else. This is made phenomena. I hope it is clear. Again, very important. These are the made impulses. The last two, write the names. I'll discuss them individually so that you have a list. So write them here, then I'll explain them one by one. Next is somatic passivity. Write them down so that you have a list. Then I'll explain you. And then it is delusional perception. So write it down. So we have 11. So now you can see there are 11 SFRS, Schneiderian's first rank symptom, 11. Okay, 6 we have discussed, 3 again made phenomena, 2 we will discuss one by one. These have been asked many times in your MCQs. So again, very important, these 2 points are very important. I'll tell you the tricks to remember: somatic passivity and delusional perception. These 2 phenomena are very, very important, very high chances question on these 2 may come. So put hashtag when you're revising, do revise this. So let's discuss somatic passivity. So 2 points remember here. So write down somatic passivity. Patient is a passive recipient of bodily sensation. Somatic means body. So patient is having some body sensation. Please remember, these can be normal perception, normal sensation, or these can also be tactile hallucination. It could be any. So there are some bodily sensation. Don't go into the detail. It is hallucination or normal phenomena. It could be any. So patient is a recipient. Passive recipient is that he is receiving these bodily sensation, which he says is imposed upon by an external agency. Very important. So these 2 points, both of them should be there. Only then we say it is somatic passivity. So patient says, doctor, I am having some tingling sensation on my arm. Okay, you may feel it could be normal or it could be a tactile hallucination, any. But he is saying, doctor, these sensations are because of some radio waves sent by my neighbors. He is saying that this is occurring because of some external agency. So now it becomes somatic passivity. Okay, so if in the option you have tactile hallucination also in the option, but if you have somatic passivity, it is a better answer. Okay. So from the name itself, can you see? Yeah, I'll give you more examples. Okay. So we'll bring a patient in the OPD soon. So basically remember from the name, always remember, if you're confused, see the name. Somatic passivity. Patient is a passive recipient of somatic or bodily sensation. Somatic passivity. Patient is a passive recipient of bodily sensations, somatic sensation, which are imposed upon by a external agency. Always look into the name and try to remember, so you'll not get confused. Okay. Yeah. So we did not say made sensations. Those were feelings or action or impulses. Here now he's saying sensations are by some other external agency. Got my point? Okay, so let's bring our patient Bolu. So we had a patient Bolu. Okay, so he complained of pain in his abdomen. He said that I have pain in my abdomen, which he say is because of some waves. It is because of some radio waves sent by aliens. So what are the two phenomena? There is a bodily sensation, right? And patient is saying it is imposed upon by an external agency. What is the phenomena? Somatic passivity. Okay, so please remember this please, it's not always that patient will say this is radio wave. It can be any reason. Patient may say that he's using telepathy, or may just say that my neighbor is doing something because of which I'm getting this sensation. Okay, so an external agency should be there. Only then we will call it as somatic passivity. Everyone clear? It's a very, very important MCQ. Please remember. It's not there. Nobody is doing it. But this is there, abnormality is there in the patient. This is not true. Yeah, the patient is feeling that. Yes, Ulu in this case, right? Now, next. Again, very interesting phenomena. Last one is delusional perception. Delusional perception. Again, this is very important. Again, there are two components. There are two stages or two steps in this delusional perception. One is patient is perceiving a normal perception. Patient is perceiving, there is a normal perception involved. Patient experiences a normal perception, right? It is a normal perception. Anyone can experience this. Suppose patient is seeing something or hearing something. There is a normal perception. Okay. This normal perception, patient gives a delusional meaning. Patient gives a delusional meaning to this normal perception. Okay. So patient and these two steps are occurring together. It's not that today he has experienced the perception and 10 days later he is developing the delusion. No. He experiences a perception and immediately he develops a delusion. Such within snap of fingers, he develops a delusion. Okay, so this is delusional perception. From the name itself, you can remember normal perception is given a delusional meaning. Yeah, they don't get developed delusion. No, so that is they're explaining. It's not a delusion. They're visualizing it as a cotton. But here, what is happening? I'll give you example so that we'll be able to understand. Let us say a person goes to a party and he sees a fork with a crown. He sees a fork or a spoon. He sees a spoon with a crown over it. This is a normal perception. It's a normal object. Anyone can see. And immediately he says, he sees the crown on the spoon. Immediately he declares, I am the king of the world. I am the king of the world. Immediately. People come and say, no, what are you saying? Wow, you're king. You earn 10,000 a month. You have a cycle. Don't have this, that. How you're the king? No, I am the king of the world. Okay, kneel below me. Okay, I am the king. I am your king. What is this? Very good. This is delusion of grandiosity. So now you are able to see what is happening. Grandiosity. Right? Delusion of grandiosity. So everyone understood? There is a normal perception which patient has given a delusional meaning. It could be any delusion. It could be any delusion. Let us bring another patient of us. Let us bring another patient. So Mr. K, okay, saw his wife wearing a red sari. Saw his wife wearing a red sari. Okay, and started saying that my wife wants to kill me. Wants to kill me. So what is happening here? This woman in red sari is normal perception, isn't it? And what the patient immediately develops, what is this? This is delusion of very good. So it could be any delusion. Okay, it could be any. Yeah.
So what is that? When you see certain numbers everywhere, like around 10, 10, 10.
Yeah. that is different. That is different. We'll come to that. Yeah, not related to this. Okay. Here patient is seeing a normal phenomena, normal perception and giving a delusional meaning to that phenomenon. Okay. So this is delusional perception. From the name you can remember, normal perception is given a delusional meaning. Please remember like this, write it like this. Believe me, it will be very helpful. Because you will be confused somatic passivity. Passive recipient of somatic sensation imposed by external agency. Okay. Normal perception given a delusional meaning. From the name you will be able to remember. These questions have been asked. Please remember this. So this was about the history. Let us discuss the epidemiology. दोनों important है. Somatic passivity, because they may not ask SFRS. They will give you a phenomena, because clinical questions are asked these days. They will tell you patient is, sees something, develops a meaning, delusional meaning. What is this phenomena? What is it? Delusional perception. Okay. So this is very important. Now let's discuss epidemiology. What is the lifetime prevalence of schizophrenia? So prevalence, in the lifetime, how many people in the population may develop schizophrenia? 1%. Very good. Lifetime prevalence is 1%. Okay. Now, there are certain important differences when a man develops schizophrenia and when a woman develops schizophrenia. Okay. Okay. Right. Okay. Epidemiology. Okay. So there are certain important points about the gender and age. Okay. Okay, I'll show the last slide. Just wait a while. I'll just again show it. Then I'll move on. This was delusional perception, which we had discussed. These two phenomena occur together. This is very, very important. Not that he sees the crown today and 2 weeks later he develops this delusion. Then it is not this. It will occur immediately. Okay. So let's discuss prevalence. 1%. Now tell me, if I ask you, schizophrenia is more common in male or female? How many of you say male? How many of you say male? No for male. How many say female? You say female? Okay, good. It is in fact same, equal. But still, if you have to choose one, DSM-5 says then it is, how many say female? Then it is 1.1:1. That is males. Slightly more common in males. If you have an option that it is equal, then you can say equal. But if you have an option to choose one, then it is males. Slightly more in males than females. Now, what are the important differences between a male? Yes, I'll come to age. That is, we are going to discuss certain important differences. No. So, what is the difference between a man developing or male developing schizophrenia and female? Of course, symptoms will be the same. I'm not talking about the symptoms. So, the peak age of onset, that means at what age maximum males will develop schizophrenia? No. It's a disease of early age. Early means young adults. It is 10 to 25 years. Majority of the males who are likely to develop schizophrenia will develop schizophrenia by this age. Okay, I'm not saying schizophrenia cannot occur in males at later age. It can, but majority, peak age. Okay, while in female, can anybody tell me? 25 to 35 years. Okay. Okay. Yes, किसी को भी हो सकता है. Anybody can have. Okay. So peak age. Okay. Second is, if I ask nowadays, when you are studying, medicine, surgery, you're talking about tumors, you're talking about prognosis, survival rate. Similarly, even in psychiatry, we're talking about prognosis. Nowadays, prognosis is very important. Prognostic factors are very important. So, what is prognosis? Prognosis basically means outcome. Someone develops schizophrenia. Is it a good outcome he will have, or it has a poor outcome in the patient? So, if I ask you gender-wise, which will have a better outcome? Men will have better outcome. So, let's understand the concept. Schizophrenia is a severe illness. Someone develops schizophrenia at such a tender age, 10 years, 15 years. So much, the age in which we learn so many things, They're not able to do. So it's a severe illness. Someone who develops it at early age, likely that his prognosis is poor. Well, females are having schizophrenia at slightly later age. So when compared, males will have poor outcome or poor prognosis. Female will have good prognosis. Okay. And in the end, I'll give you a list of prognosis. With this, that table will be very important, but this is one important difference which I want you to remember. Okay. And why we have discussed. So you will not get confused. Okay. Right. Now, we have discussed dementia. I have told you dementia is a disease of late age. But then I told you there are certain people who develop dementia at an early age. So we gave that term early onset dementia. In schizophrenia, it is the opposite. I am saying schizophrenia is occurring at a young age more. So someone develops schizophrenia at late age for the first time. We call it as late onset schizophrenia. So everyone understood what is late onset, why we are calling it late onset and not early onset schizophrenia? Because most of the schizophrenia occur at early age. But some who does not, then we say it is late onset. Now again, this is a very important MCQ. When do we call it as late onset? So onset, after what age? For the first time, patient develops symptoms of schizophrenia. After which age? We call it as late onset. Anyone? 35? No. 65 between them. 45. Let's do a bargain and let's call it as 45. So someone have an onset after 45 years of age for the first time. Suppose a patient develops schizophrenia at 30 years. Later again at 60 years he also develops schizophrenia. That is not late onset. He already had developed schizophrenia before. I'm saying for the first time. If he develops schizophrenia after 45, it is late onset. So this is very important MCQ. This has been asked many times. What is late onset schizophrenia? If I ask you, late onset will have good prognosis, poor prognosis? Good, very good, good prognosis. Now, let's come to the etiology. Again, now please understand, any psychiatric illness does not have one particular cause. Other medical conditions, surgical condition have one etiology. The COVID pandemic has an etiology. What is the etiology? The COVID-19 virus. Okay, so there is an etiology. But in psychiatric condition, we have many etiologies. Many factors come together and then they lead to psychiatric illness. Genetic factors, neurochemical factors, physiological factors, psychological factors, environmental factors, so many factors come into picture. Okay, I cannot say that schizophrenia occurs because of one factor. Okay, so let us understand certain important etiological factors. One is genetic factors. There are many important genes which are involved in development of schizophrenia. Okay, so one is genetic factors. Now again, there is no one particular gene. Many genes have been identified. More than 20-25 genes we have identified in different population which can lead to schizophrenia. So we will not go into all those genes. And also you can see that many times patient who has schizophrenia, there may be a positive family history. Again, this is a sign that it is seen in families. Not always, but many a times. Okay. Now one important syndrome which you can remember, you must have read in your other subjects, chromosome 22q11.2 deletion syndrome. Okay, so in pathology especially you will read this Dijord syndrome. Dijord syndrome is a chromosome 22q11.2 deletion. So there is deletion at this particular site. Okay, also known as Dijord syndrome, also known as velocardiofacial syndrome. Okay, velocardiofacial syndrome. Okay, so there is in these patients it is seen there is an increased risk of schizophrenia. There is an increased chances. Okay, in this. Now there are many other genes also. Will not go into those specific genes. Okay. So one is genetic factors. Okay. Now second, neurotransmitter. This is very, very important. Highlight this in your notes. Highlight this in your note. This which we are going to discuss is very, very important. I'm going to discuss certain important concepts here. It's very, very important. Okay. So neurotransmitters. Everyone has written genetic factors. So then next is neurotransmitters. Especially for schizophrenia, this is very important. Okay. First is dopamine. So there was a dopamine hypothesis in the past. So there was a dopamine hypothesis. So if you are asked, dopamine hypothesis is for which disorder? For schizophrenia. So dopamine is a neurotransmitter. Okay. So this, what was the hypothesis? It was seen that patient with schizophrenia, there is an increase in dopamine in the brain. DA is dopamine. So this was the hypothesis. It was in the 1950s. This was hypothesis which was given in 1950. They said patient is having schizophrenia. It is seen that with schizophrenia there is an increase in dopamine because of which symptoms develop. Okay, but our understanding about these improved. So now we know that there are various dopamine pathways in the brain. Okay, again these are some biochemistry questions you may get. Okay, so there are 4 dopamine pathways. 2 pathways we are going to discuss here related with the symptoms. Okay, so 2 pathways we are going to discuss. So let us discuss some dopamine pathways. So there are 2 important dopamine pathways in the brain. One is mesolimbic. One is mesolimbic dopamine pathway. One is mesolimbic. Mesolimbic. Meso means midbrain. Very good. Which part of the midbrain? Ventral tegmental area. Have you heard this term? VTA. Have you read reward circuitry? Reward circuitry. So there is a reward circuitry. Many of the addictions which we get is because of stimulation of this reward circuit. Okay. So this basically starts from midbrain. Which part of the midbrain? VTA. Ventral tegmental area. To the limbic system. It goes to from midbrain to the limbic system. Which part of the limbic system? Nucleus. Let me write it again. So it goes from midbrain to nucleus accumbens. Okay, nucleus accumbens. Okay, so it's just remember from midbrain to limbic system. So from the name mesolimbic, meso midbrain to limbic system. Now, what is happening here is in this pathway in patients with schizophrenia, what is happening is there is a increase of dopamine. Okay, so increase of dopamine is occurring in this pathway. Okay, so increase in dopamine is occurring in this pathway. Okay, what it is leading to? It is leading to what is known as positive symptoms in schizophrenia. So if I ask you positive symptoms of schizophrenia occur because of what? They occur because of increase in dopamine in this pathway. Okay, what are the important positive symptoms? Delusion and hallucination. We have already discussed, so we just write down. So delusions and hallucination are the positive symptoms of schizophrenia. Okay, so delusion and hallucination, important, right? Okay, so delusion is disorder of thought, false fixed form belief. Hallucination we have discussed, it is a disorder of perception. Both are positive symptoms of schizophrenia. Okay, both are described as positive symptoms of schizophrenia. Second pathway is second pathway is mesocortical pathway. Mesocortical pathway, again, meso means VTA, ventral tegmental area or the midbrain. Cortex, it goes to the cortex. Which part of the cortex? To the frontal cortex. Which part of the frontal cortex? Prefrontal cortex. Very important part of the brain, especially for psychiatric problems. Okay, prefrontal cortex. What is happening here is there is a decrease in dopamine. Here in this pathway, there is actually a decrease in dopamine. So that earlier hypothesis that there is an increase in dopamine in schizophrenia is partially correct, because we know in this pathway there is a decrease of dopamine. And what does it leads to? It leads to, very good, it leads to negative symptoms. I'll talk about negative symptoms in a while. So remember this concept. Okay, so this is again important. So we know that there are many pathways. These two important dopamine pathways are responsible for the positive and negative symptoms of schizophrenia. Okay, everyone has written this? Okay. Right now, so this was again, our understanding has been improving more. Our understanding has been improving more. Now we say even other neurotransmitters are also implicated in development of schizophrenia. So for example, we say now even transmitters like serotonin, norepinephrine, glutamate, any neurotransmitter you can think of, acetylcholine, GABA, nicotinic, any neurotransmitter you can think of. Now we say all of them are implicated. All of them have some changes which leads to development of schizophrenia. So this is again very important. Now we don't say only dopamine, but even other neurotransmitters. Suppose there is a question, neurotransmitter in schizophrenia which is affected. Suppose the option is dopamine, GABA, serotonin, 5-HT is serotonin, fourth is all. Answer is all. Very good. Another set of options, suppose same question options are dopamine, GABA, serotonin, acetylcholine. Answer will be all is not there in the option. So we know all are correct, but best is dopamine. Okay. So sometimes all the options are also correct in the answer. Okay. We have to choose the better answer. Okay. So please remember. So sometimes in this question, you just see dopamine, you mark dopamine. Okay. You have not read all the options. So always read all the options very carefully. Even if you think you know the answer, even if you are 100% sure about the answer, always read all the options carefully. Otherwise, many times we just mark dopamine in this answer. Okay. So this was about etiology. Let us now come to the symptoms. So we have discussed about etiology. Now let's discuss what are the important symptoms. Again, many symptoms we have already discussed. So we'll just name them. Positive symptoms we know they occur because of increase in dopamine in the mesolimbic pathway. Okay. Delusion and hallucination. Can anybody tell me most common delusion? Very good. Delusion of persecution. Can anybody tell me most common hallucination? Very good. Auditory. Although any delusion, any hallucination can be seen. Right? So we have discussed this. Second, let us discuss, write it down, then I'll discuss negative symptoms. Okay. Delusion. Delirium is a separate disorder altogether. It's a separate diagnosis. Okay. In schizophrenia, impairment of consciousness is not there. Okay. In delirium, there was impairment of consciousness, cognitive symptoms. Remember, check consciousness is MS, right? Now, next is any delusion. Any delusion you can think of, any hallucination you can think of. I'm just telling you most common also. Okay. Most common in organic mental disorder, hallucination was visual. Okay. Negative symptom, 5 negative symptoms, right? Okay. Just write delusion and hallucinations. Okay. So these are seen, these are positive symptoms, right? Organic is more visual. In organic mental disorder, which hallucination is more common? I asked. It was visual. Remember? Yeah. Okay, now let's come to negative symptoms. So there are 5 negative symptoms. Let us discuss them one by one. First is anhedonia. We have already discussed what is anhedonia. Loss of interest in activities or pleasurable activities, right? Anhedonia. There is a decrease or loss of interest, right? Second is, what is volition? Volition is will to do something. Avolition is loss of will or drive. Family members will say, doctor, no, he does not do anything, as if he has lost all his motivation to do anything. We give him some task, he does not perform, as if he has lost all the will to do things. There is loss of will or drive to do things, right? Again, next we have discussed affective or affect blunting. We have already discussed. Flat, remember, flat affect, blunt affect. There was no change in emotion. So there is inability to express emotions or loss of ability to express emotions. Okay. Next is asociality. Okay. Next is asociality. So again, from the name itself, patient becomes asocial. There is a decrease in drive to socialize. Family members say, doctor, anyone comes at home, he does not, socialize with them, does not talk to them. He goes out, we take him outside, he does not socialize now. So there is decrease in the ability to socialize. Okay, asociality. Socially, the person is withdrawn. Last is alogia. What is logo? Means word, right? Remember neologism, new word. Alogia means less words. So there is a decrease in verbal communication. Patient will, family members say, doctor, I ask him a 10-minute question. For 10 minutes I'm speaking, I ask him something, just 1 or 2 words he will give. So there is very much decrease in the verbal communication. Okay. So now can you appreciate that everything is decreasing? Everything is decreasing, getting subtracted, getting minus. That is why we call them as negative symptom. Okay. Most common negative symptom is anhedonia. Okay. Out of these, most common is anhedonia. So remember I told you, anhedonia can be seen in depression. Anhedonia can also be seen in schizophrenia. So we have discussed this, right? So this is important. Right? Everyone has written this? Okay, so these were 2 symptoms. Let us discuss the third set of symptoms in schizophrenia. Just see. So let us discuss the next set of symptoms. Disorganized symptoms. This is the last set of symptoms in schizophrenia. Now, if you don't know this symptom, I'll come to the diagnosis. Why I am discussing all these? Because when I'll tell you the diagnosis, if you don't know these symptoms, you will not be able to make the diagnosis. Okay, so let's discuss the last set of symptoms. Disorganized symptoms. Okay, disorganized symptoms. So disorganization can occur at the level of speech or it can occur at the level of behavior. Okay, so we have already discussed one, disorganized speech or thought. Remember we discussed in thought, we discussed flow, form, content, possession. Which one was for disorganization? Flow, form, content, possession. Content was delusion. Form. Remember form. It was, remember, don't worry if you make wrong answer right now. Make as many mistakes as you want to. This will help you remember. Okay. Try to answer as many things as possible. This will help. We'll discuss in the end. If you give me some time in the end, we'll discuss how to plan, out the revision. Okay, we'll discuss about this later. Okay, so disorganized speech we have already discussed. Formal thought disorders. Remember, any formal thought disorder you can think of. Loosening of association. Remember, neologism, tangentiality, all these we have discussed. So I'm not going to discuss again. I told you there, formal thought disorder more commonly, very commonly seen in schizophrenia, right? We have discussed that. Next is disorganized behavior. So patient may have certain behavior like, family members say, doctor, he puts hand in the garbage and picks out things and starts eating. Very disorganized behavior. Okay, so very severely disorganized behavior can be there. Okay, and sometimes patient may have some motor symptoms. Patient may have some motor symptoms which is known as catatonic symptoms. Very, very important. Many questions have been asked on catatonia. Many questions. This is very, very important topic which I am going to cover here only. Catatonia is very important. Sometimes they ask direct question only from catatonia, not related to schizophrenia. So what is catatonia or catatonic symptoms? So let us come to catatonic symptoms. So let us discuss catatonic symptoms. These are motor symptoms. Now please remember this, please understand this. Just like fever is not a diagnosis, fever is a symptom. Fever can occur in bacterial infection, viral infection, malignant hyperthermia, and whatnot. Fever is a symptom. We don't say fever is a diagnosis. Similarly, catatonia or catatonic symptom these are set of symptoms. Catatonia in itself is not a diagnosis. One point. Everyone understood? Catatonic symptom is just set of symptoms. It can occur in many conditions. So second point is catatonia can occur in many conditions. When we are discussing catatonia here, but that does not mean that catatonia is only seen in schizophrenia. In fact, catatonia is more common in mood disorders. Okay, so let us discuss certain symptoms of catatonia. I've clubbed them together. I've grouped these symptoms so that it becomes easy to remember. Okay, let us discuss first three symptoms. One is stupor. First is stupor. What is stupor? When there is no or significantly decreased PMA is psychomotor activity. Psychomotor activity. Psychomotor activity. That means the activity of the mind, psychic activity and motor activity are low. Patient is just lying down on the bed, not responding to external stimulus. So he is in a state of stupor. Okay, there is no or significantly decreased psychomotor activity, right? Clear? Second, it can be opposite. Patient may be in a state of excitement. There is significantly increased psychomotor activity. So please understand, I'll give you a number of symptoms. I'm not saying that all the symptoms should be present. If someone has 3 or more symptoms, we'll say patient has catatonia. Okay, so some patient may be in stupor state, some patient may be in excited state. Patient is severely excited, moving around here and there, removing things, just not sitting at one place, severely excited. Okay, so there is increase in the psychic and the motor activity. Then third is mutism. Just like you can mute a television, so the images are going on. Okay, so images are going on, but you are not able to hear anything, right? Similarly, the patient is doing everything, but he is not speaking anything, as if you have muted the patient. Okay, so this is mutism. There is no or little verbal response. Okay, there is no or little verbal response. This is mutism. In allogia, yes, so in allogia, I am saying if it is occurring alone, if mutism is occurring alone, then I will not call it as catatonic symptom. So to call it catatonia, it should have other symptoms also. Okay, so if his patient is having mutism, also having other symptoms, then you think about it as mutism. Yeah, then we will say yes. So patient should have other symptoms also. Okay, and in mutism, patient will otherwise be doing everything normal. All things he is doing, right? So these are the first three symptoms. Next two symptoms, again very interesting. So two symptoms we will discuss together. So two set of symptoms we'll discuss together. Catalepsy, please write down catalepsy. Okay, catalepsy. Please remember there is something known as cataplexy also. So please remember this. This is catalepsy, and another is posturing. Catalepsy and posturing. Okay, catalepsy and posturing. Okay. So both of them are basically abnormal maintenance of posture. Both of them means that there is abnormal maintenance of posture for a long time. Both of them mean the same. There is one important difference. Catalepsy, posturing both mean that there is abnormal posture which the patient is maintaining. What is the difference? Yes, catalepsy is a passive phenomena. Passive means someone else is made the patient to have this posture and now he is maintaining it on his own. Active posturing means it's an active process. He himself has stood in this posture from the beginning. Okay, so write it down, then I'll explain you with this with the example. So this patient which you are seeing, now, is it a very normal posture or very abnormal posture? Try to maintain this posture for a few seconds, you may fall down. If you are an acrobat or you have been practicing yoga, you may be able to do it, but normally very difficult to maintain this posture. But this patient may maintain this posture for hours. Okay, so how to say that it is catalepsy or posturing? But what is it? Is catalepsy or posturing? How to say? Just by seeing the image, I cannot tell. If you are told that this examiner has made the patient to stand like this, then it is catalepsy. If the patient himself is standing like this, it is posturing. So don't ask me, sir, if this image is given, how do we differentiate? They will not give both the options. If they will give both the options, they'll tell you whether patient is maintained himself or by someone else. Okay, so this is catalepsy and posturing. Okay, now next symptom, waxy flexibility, very important. I don't know why, but whenever question on catatonia comes, more often they will give you this symptom. Okay, it's not that it's a very it's a very specific symptom, but many times you will get this symptom. What is waxy flexibility? Waxy flexibility means is flexible like a wax, or patient can be molded like a wax candle. Okay, so person can be molded like a wax candle. So basically it's a sign. It's a sign which we test. So when we check waxy flexibility, suppose you try to move the patient. So when you mold a wax candle, so initially there is resistance. After this, you can mold the candle as you want. Okay. Similarly, when I try to move the patient, initially the patient will show resistance. After this, I can mold him the way I want. This is waxy flexibility. Okay. Person can be molded like a wax candle. It's a sign. It's a sign which we see in the patient. Okay. So this is waxy flexibility. Now, next two symptoms again, let us discuss them together. Negativism. Now, there was a very beautiful question in 2019. I will discuss that question in the end on catatonia. They're given such beautifully, they framed the question that it was very important. If you don't know these in detail, you will not be able to solve. Okay, a very direct question was asked. I'll show that question in the end. So let's talk about negativism. So from the name itself, person has very negative attitude towards the examiner. Okay, so what happens in negativism? Patient either give no response, patient gives no response or oppose the instructions. Okay, so he's having very negative attitude towards the examiner. He either gives no idea, oh, I don't want to give response, he's thinking like this, he does not give any response, or he may just oppose it. Whatever you tell him to do, he'll do the opposite. Okay, so this is negativism. For example, you put your hand forward to shake the patient's hand. Patient either will just stand like this or will pull his hand backwards. Okay, you try to pull the patient towards you. Patient either will, hold you with the same force or may push you towards him. So never try this with a patient who is having negativism. Okay, so he's opposing or giving no response. Okay, this is the symptom. If you ask the patient will not say that it is intention. This is the symptom which the patient is having. Okay. Now, next is opposite of this is automatic obedience. This is opposite. Now he is extremely cooperative. Now whatever you do, you tell him jump in the well, he will jump. Now he's that much, he's that much cooperative. So there is extreme cooperation. Okay, so there is extreme cooperation. Even if it is detrimental to the patient will follow your command. Okay, so automatically now he is obedient. He's become obedient. Whatever you say, he will do. Okay, so again, these two symptoms you can remember together. One is negativism, one is automatic. So one option was the question which was asked on catatonia. How beautifully they framed the question. They asked which of the following is seen in catatonia. One of the option was positivism. There is no term as positivism in catatonia, but they just framed the question so well. Now, next two symptoms again. These two symptoms, yes, right? Everyone has written this, right? Okay. Now, next two set of symptoms. Again, questions on mannerism and stereotypies have been asked separately also. So you should know what are these. Okay. So one is mannerism and stereotypy. Again, you can remember them together. Okay. So both of them are repetitive odd movements. Okay. So both of them are movements, odd movements, which are occurring repeatedly. Okay. So both of them are repetitive odd movements. Okay. So both of them are repetitive odd movements. Odd. You'll find them very odd. I'll explain you. So they're very odd. Okay. Now, but what is the difference then? So from the name itself, mannerisms have some manner, or these movements have some purpose. Okay. So these are basically purposeful movements. From the name you can remember they have some manner. They have some purpose. So these are purposeful movements, while stereotypy are non-purposeful movements. They are non-purposeful movements. Okay. So these are purposeful movements and these are non-purposeful movements. Okay. So for example, a person is doing this. There's a salute sign, patient is doing this movement, seems like a salute, but now he's doing it repeatedly. He's not stopping and doing repeatedly. Now it becomes odd. Okay. So it is mannerism or stereotypy. It is mannerism because it has some purpose. Suppose a patient is doing like this repeatedly. There is some abnormal movement, but it does not have any purpose. Okay, so this is stereotypy. Okay, so many of your film dances steps, all those are stereotypies. They don't have any purpose. Okay, it is occurring abnormally. It's not occurring one time. It is repeating itself. That is why it becomes now abnormal. Movement. Here we are talking about movement. Only movement. Yeah, it is continuous. Mannerisms, right? Yeah, any movement which does not have a purpose, it is stereotype, right? Now, next two symptom again very interesting. One is echolalia or echolalia, okay, and the other is echopraxia. Echolalia and echopraxia. Echo means to repeat. Echolalia and echopraxia. Okay. So what is echolalia? Patient is mimicking. Very good. Lalia means words. Patient is mimicking examiner's speech. Is echoing whatever the examiner is speaking. So the examiner asks the patient, what is your name? Patient says, what is your name? What do you do? What do you do? Okay, so he repeats it. Okay, while what is echopraxia? Praxia means, remember apraxia, loss of praxia, fine movements, unable to comb, unable to button, unbutton. Praxia means movement. Echopraxia means mimicking examiner's movement. Okay, always remember from the name, examiner's movement. So that's when saying these terms will appear very alien, but once you start getting their names, you'll be able to remember. Echopraxia. Okay, so suppose you're writing something in front of the patient. Although the patient is not having any pen and paper, you will also start mimicking. A very interesting way to see this, examine this, start scratching your head in front of the patient. Patient will also start scratching. Okay, so this is echopraxia, right? Now, last two symptoms of catatonia. No, he'll not say follow a command. He'll follow whatever you're doing. He'll start doing that. Yes, very interesting. Next is grimacing. Grimacing is basically, what is grimacing? It is maintaining odd facial features. So nowadays when you take a selfie, what do? You pout. So if you maintain that pout for a long time, that is grimacing. Maintaining an odd facial features for a long time. Okay, so grimacing. Last is ambitendency. You remember something we discussed related to ambivalence? Ambivalence was inability to decide at the level of thinking. It is inability to take motor decisions. Okay. So now this is occurring at the level of movement. Okay. So for example, there is pen on the table. Patient who is having ambitendency will move his hand forward, backward, forward, backward, as if he's stuck. He's not able to make the decision. So his movement is stuck. He will continuously be stuck in this movement. Okay. So this is ambitendency. While ambivalence was occurring at the level of thinking, he's just staring and thinking whether I should pick it up or not. Okay, so this is the difference. These are motor symptoms, so it is at the level of movement. Okay, so these are the symptoms of catatonia. So if we say that there are 3 or more symptoms present in a patient, we say patient is having catatonic symptoms. Okay, now let us come to the diagnosis. We'll just let me finish the diagnosis, then I'll take a break. Okay, then we'll take a break. 9 o'clock I was told. Let's start. I think you have a class. There is some class at 4. Let's get into DSM-5. So there are 5 symptoms. 5 symptoms are there. There is a reason I've written them separately in this particular way. One is delusion. So you can see delusion. I'm not saying which delusion. Any delusion. Okay, any delusion. Second is hallucination. Again, I am not mentioning which hallucination. Any hallucination. Right? Third is disorganized speech. Third is disorganized speech. Right? We'll take a break shortly, don't worry. We'll finish this and then I'll take a break. Now, last 2 are, so disorganized speech again we have discussed. Disorganized speech or disorganized thought, like loosening of association, neologism, all this we have discussed. Next is disorganized or catatonic behavior. So if we don't know what is catatonia, we will not be able to understand the diagnosis, isn't it? And last is negative symptoms. So you can see all of these symptoms we have discussed, right? Now, so what is the catch? So these are the 5 symptoms which are mentioned in DSM-5 for schizophrenia. To make the diagnosis of schizophrenia, they say 2 or more symptoms should be present. Okay, so 2 or more symptoms should be present, but at least one symptom, so you can write down at least one symptom should be from first 3. So we say, so everyone understood this, that out of these five we say 2 or more symptoms should be there to make the diagnosis of schizophrenia, right? But out of those 2 symptoms, at least one symptom should be from first 3. Okay, the first 3 are delusion, hallucination, and disorganized speech. Okay, it could be 3 symptoms, 4 symptoms, or all the symptoms are there. Minimum 2 symptoms are required. Suppose a patient has delusion, patient has disorganized or catatonic behavior, it is schizophrenia, right? Suppose a patient has hallucination and also has disorganized speech. Is it schizophrenia? Yes, it is. Okay. Now, all these symptoms should be present. So I told you criteria. To fulfill the criteria, the symptom requirement. What is the duration? To make the diagnosis, what is the duration? 6 months. Very good. 6 months. Very important. Okay. 6 months. We'll discuss some examples so that it's become very clear. Okay. ICD-10 says the duration is 1 month. Again, they may not give you both the options. Okay, please remember. So they may give you options like, suppose they are asking about duration of schizophrenia, and the options are 1 month, 2 months, 3 months, 4 months. Answer is
1 month.
so most likely they are asking about ICD. Okay, and suppose the options are 3 months duration for schizophrenia. One option was 1 month, 2 month, 3 month, 4 month. Answer in this case would be 1 month. So maybe they are asking about ICD. Then another option 3 months, 4 months, 5 months, 6 months. Answer is 6 months. If still they give you both the option 1 month, 6 months, they will tell you according to which. Still if done, then you can go for 6 months. Okay, according to DSM-5, right? Yeah, 6 months according to DSM-5.
Sir, how many symptoms should be positive for catatonic?
3 symptoms or more. 3 or more symptoms of catatonia, we say it is catatonic symptom present. Right? Now, let us discuss a question so that it becomes very clear. So let us, a 20-year-old male claims that his college principal along with some teachers are planning to fail him and want to expel him from college. He complains that they are continuously talk about him, which he is able to hear even at his home. He has stopped going to college and says that he will take revenge from his college people. His friend have noticed anything like this in the college and try to convince him, but he is not convinced. Self-care is deteriorated. So tell me, what are the symptoms first? What is this symptom? Planning to fail him, want to expel. Their delusion of, very good. This is delusion. Delusion of persecution, people wanting to harm me. He is also able to hear them. This is auditory. This is auditory. Just auditory saying is also enough for this diagnosis. Hallucination is there. Hallucination. So let us say it is present for 7 months. Diagnosis? Schizophrenia. Minimum 6 months is required. Symptoms are present for 7 months. Yes. Okay. 2 symptoms are there, and at least one of the symptoms should be from first 3. Both of are there from first 3. Delusion and hallucination. Right? Another question. Let's see if we are able to answer this. So a patient is suspicious, suspects neighbor wants to kill me, they want to harm me. Okay. He talks less, has decreased interest, has decreased socialization, not meeting people, symptoms present since 8 months. Is it schizophrenia? How many of you say schizophrenia? How many of us say schizophrenia? How many of us say no, not schizophrenia, something else? What is this suspiciousness? Neighbor wants to kill me. This is delusion. Delusion, persecution of course, but delusion. Patient is talking less, decreased interest, decreased socialization. What are these? Negative symptoms. Let's go to the diagnosis. So patient is having delusion. Patient is having negative symptom. What was the duration? 10 months, 8 months. So 2 or more symptoms are there? Yes. At least one symptom is from first 3? Yes. Delusion is there. Duration 6 months at least? Yes. Answer is schizophrenia. If only disorganized and negative symptoms are present in the patient, is it schizophrenia? No, it will not be schizophrenia. Right? So this is how we make the diagnosis. Please remember, in the question, they will not give you patient is having delusion, patient is having hallucination. No, they will give you the symptoms. You have to make the inference what is the symptom. Right? We'll discuss these such questions more. So let's take a break. Okay, let's take a small break and then we'll start. Have come from this topic. Okay, so the answer is thought. Thought, right? We'll share these questions. Don't worry, just try to attempt these questions. Okay, okay. Thought. If they have to be more specific, they will ask you. Delusion is a disorder of flow, form, content, possession. Content. Very good. This was June 2019. So please see, even in 2019 June paper, they were asking clinical question. Patient says, home is sweet, sweet in diabetes, diabetes urine has smell, smell is hell. Patient is speaking so many words, which is not making any sense, but connection by chance is there. Answer is flight of ideas. It is not loosening. It is not neologism. It is not tangentiality. Right? So this such good question they have asked. Right? Now next, December 2019. Again, such a simple question. Person finds decrease in pleasure. Very good. Anhedonia. Very good. Next. Now this was a controversial question somehow. Although it's a very, if you see the option, it is very simple. Let us see this question first. Patient says, a psychiatrist asks the patient, how is your mood? Patient replied, it is up and down. Simple. Let us discuss. Let us discuss. So if such questions which you find are not direct, you have difficulty, always try to rule out the options. Is it neologism? There is no new word which the patient has developed. Is it clang association? Believe me, for clang association, 3-4 words are not enough. Patient is speaking very fast, he will speak so many words which will be connected. It will not be clang association. Right? Now, let's come to derailment. What is derailment? Person is on track, suddenly derails. We don't know whether he was on track or not, whether he is deviated or from the topic or not. Right? No derailment. Why is it tangentiality? You ask the mood, how is your mood? He says up and down. He's touched the topic. We don't know what do we mean by up and down. You may think up and down means happy and sad. We don't know. He just touched the topic. Maybe he will go away. Again, it is not mentioned here, but out of the 4 options, the best answer will be tangentiality. Many of your guidebooks answer is wrong. Answer is best possible answer is tangentiality. Very important. So you can see recent questions even in 2019 they were asking such questions. Okay. Simple question, drug of choice, Alzheimer's disease. Mechanism. Acetylcholine esterase inhibitor. Right. Good. NMDA antagonist. Memantine. Monoclonal antibody. Ida-Canin. Yes. This was the question in June 2021. Deficiency of which of the reason for cognitive impairment? Very good. See, such simple questions have been asked. Everything is from your notes. Next. Diagnosed with Alzheimer's disease, neurotransmitter which is implicated. Again, this is June 2021. In the end, we'll all discuss again all the questions again. So let us start with schizophrenia. So let us start with schizophrenia. Okay. So we have discussed the diagnosis. Right? So let us discuss various subtypes. Let's settle down. Let's start the class again. So subtypes of schizophrenia. So there are various subtypes. Few things I want you to remember about subtypes is DSM-5 has removed the subtypes. DSM-5 says no need to subtype, just call it as schizophrenia. No need to say it is paranoid, epiphrenic, no need. Just say schizophrenia. But ICD-10 still follows this. ICD-11 is also planning to remove this. But still you should know subtypes because many questions, even from your recent exam, the questions have been asked. So there are various subtypes. So this is one table again. Put a hashtag on this table. 2 tables I'll give you in schizophrenia, which will be very, very important. Okay, one of the table is this. Whenever you are revising schizophrenia, do revise this table. In this one table, we'll at least solve 10 to 12 questions. Okay. So let me give you a mnemonic to remember. PHC, Primary Health Center, is the USP of our country. PHC is USP. Okay, this is the mnemonic so that we can remember all the important subtypes. Right? So let's go one by one. Write the way I am writing. It will help you to make a small table. Okay. So very useful for your exams. First is P is paranoid schizophrenia. P is paranoid schizophrenia. In paranoid schizophrenia, predominantly patients has delusions and hallucinations. So predominantly patient symptoms are delusions and hallucination. Other symptom may be there, but predominantly these 2 symptoms are there. Right? Now, please remember this is the most common subtype. So one question, which is the most common subtype? Paranoid. Okay. Tell me. So generally it occurs at late age. It has late, I'm not saying late onset schizophrenia. I'm saying at a later age, maybe in late 30s or 40s, okay? Slightly late. Okay. So tell me, how is the prognosis? It has a good prognosis. Very good. Right? So this is first. This is first subtype. Paranoid schizophrenia, where patient can have any delusions and any hallucination. It's not only persecution. Any delusion can occur. Any hallucination. Don't think paranoid means persecution, any type. Okay. Second is hebephrenic. Second is hebephrenic schizophrenia. In hebephrenic schizophrenia, predominantly there are disorganized symptoms, disorganized thought, disorganized speech, disorganized symptoms are there, right? Many times they will give these terms. Patient is giggling, okay, or patient is smiling to self. Patient is giggling, smiling to self, or patient is mirror gazing, standing in front of the mirror and gazing for a long time. Again, all these symptoms are telling you that there is some problem in the organization. Okay, again, all these symptoms are associated with hebephrenic schizophrenia, right? Hebephrenic schizophrenia has early onset. Many a times you will find children, young adolescents developing schizophrenia with hebephrenic schizophrenia. Okay, so at young population develops. So tell me, it has good prognosis or yes, it has bad or poor prognosis. Okay, right? No. So this was second. So just these few points and will help you solve many MCQs. Third is C, PHC. C is catatonic schizophrenia. C is catatonic schizophrenia. What is happening in catatonic schizophrenia? Predominantly catatonic symptoms. Please remember, I am not saying other symptoms cannot develop. Of course, other symptom has to be there to make the diagnosis. Just from catatonic symptom, you cannot make the diagnosis of schizophrenia. So when we are subtyping it, I am saying the diagnosis of schizophrenia is confirmed. Then I am subtyping it. Okay, that means other symptoms are also there. But predominantly catatonic symptoms, mutism, waxy flexibility, echolalia. So those symptoms are there. Okay. Now, one point which I want you to remember here is treatment. It's a very important point. This has been asked recently. What is the general treatment of schizophrenia? Antipsychotics, right? We use antipsychotics. But here in this particular type of schizophrenia, we don't say the drug of choice are antipsychotics. A person comes to us, family members say, doctor, this person is standing like this for hours. He's maintaining these odd postures for hours. He's not eating properly. So patient is being brought in a very disabled condition. Okay, there is one drug. I give this drug IV to the patient. Many times you see magic. Patient improves suddenly. Family members feel, oh, doctor has done some magic. They start, touching your feet at times. Oh, you just, revive the patient. Such drastic improvement. Okay. So what is that drug which we may use? That is very good. Lorazepam. It may be given as IV, IM route, and later on we may. It's not that after one drug patient will cure. Symptoms will improve. Again, we have to give it. So we give in divided doses. We have to give it for some time. Sometimes even antipsychotics have to be added, right? But patient shows good improvement. Okay. Sometimes yes. Sometimes patient who does not show good response with lorazepam or show response, but again the response goes away and only lorazepam is not working. Then what is the next important treatment which we can use is very good. ECT. ECT is electroconvulsive, very good, therapy. Okay, ECT, electroconvulsive therapy. Okay, so this question was recently asked. A patient is having waxy flexibility, mutism, patient is having echolalia, treatment. Options were lorazepam, antipsychotic, antidepressant, imipramine, lorazepam. Please remember this question has been asked. So very important. Now, tell me, such patient, what will be the prognosis? Will it be good prognosis or bad prognosis? There is one drug which is showing such significant improvement in such short duration. Is it good prognosis or bad prognosis? It is good prognosis. In fact, it is the best prognosis. If you are asked which schizophrenia has best prognosis, very important MCQ. Some books have mentioned paranoid, but when paranoid you have to choose In that question, option of catatonia was not there. Please remember, best is catatonic schizophrenia, very important. Okay, now next is undifferentiated. You know, when you in pathology, when you're not able to identify the cell, whether it is, it is a cuboidal cell, columnar epithelial cell, when you're not able to see, appreciate what type of cell it is, we say it is undifferentiated. We're not able to decide. Similarly, if the patient has mixture of symptoms, okay, some paranoid symptoms, some schizophrenic symptom, some catatonic symptoms. So there are mixture of symptom, no predominant symptom. We call it as undifferentiated schizophrenia. Okay, so USP U is undifferentiated. Right? Now, next is, so USP S is simple. The name is simple, but the disorder is very complex. Subtype is very complex. Simple schizophrenia. Okay, what is happening in simple schizophrenia? Predominant negative symptoms. I am not saying only negative symptom. I am saying predominant negative symptom. ICD-10 says, okay, you made the diagnosis of schizophrenia. ICD-10 says that to call it as simple schizophrenia, wait for at least 1 year. If the symptoms are present continuously for at least 1 year, then call it as simple schizophrenia. You made the diagnosis of schizophrenia, but to call it simple schizophrenia, symptoms should be present for at least 1 year. Why is this? Why is this that we are doing this? What is the prognosis of simple schizophrenia? Good or poor? Poor. In fact, worst prognosis. So the patient outcome is very poor, very worst prognosis. That is why ICD-10 says take time. Don't be in a hurry to make the diagnosis of simple. Treatment will continue. But we are subtyping, we are taking time. Because we say sometimes the negative symptoms go. Suppose you started treatment 1 month later, that is 7 months, and symptoms went away. So it is not simple. Because in simple, they respond to medicine is very poor. Okay, so that is why we say, so suppose you've labeled someone simple schizophrenia, you have to tell the prognosis to the patient or the family. So you should take time. So this was simple schizophrenia. You know what is, which has best prognosis, which has worst prognosis. Again, in many books, they have given epiphrenic schizophrenia as worst prognosis. No, simple schizophrenia has the worst prognosis, right? Last is USPP is post-schizophrenic depression. Last is post-schizophrenic depression. Okay. So in post-schizophrenic depression, patient has schizophrenia in the past 1 year. So patient develops schizophrenia in past 1 year. Okay. So in the past 12 months or 1 year, patient had schizophrenia. Now symptoms have resolved or symptoms have significantly decreased. Okay. So patient had a history of schizophrenia in the past 1 year. Patients you treated, symptoms have decreased, and now patient is having depressive symptoms. Okay. And now the patient is having depressive symptoms from the name itself. Post-schizophrenic depression. Depression post-schizophrenia. After schizophrenia. Okay. So this is post-schizophrenic depression. Now please understand this. The risk of suicide in schizophrenia in general is increased. Sometimes patient, comes, patient has attempted suicide. We get to know, we ask, what was the reason? The family members of patient who might have survived the suicide. Okay. Will say, doctor, I was hearing a voice which was telling me to jump. Okay. So suicide is common much more than in general population. Okay. So there is increased risk of suicide in schizophrenia. Even more in this subtype, because now patient has also developed depressive symptom. So increase risk of suicide even more. So I am saying even in overall schizophrenia, there is an increased risk of suicide, but even higher in this. So we have to be careful. Okay, we need to be careful. right? So these are the important subtypes. Now this one table is solving many MCQs. This is very important table. When you are revising schizophrenia, do revise this table. Okay, many times they are asking, again, it is because it is getting removed. So this may be the time in the next few years they will ask question. Maybe after 5 years they may not ask anything from this. Okay, because our concepts are changing. So again, this is very important. Right, now next table, everyone has written this? Good. Next table which I want you to remember, this is the next table which I want you to remember when you are revising schizophrenia prognosis. As I told you, prognostic factors are very, very important nowadays. Okay, so let's make a table of good prognostic factor and bad or poor prognostic factors. Prognosis, no, not death, outcome. That means his functioning, his outcome, whether he is able to perform other things later on, okay, whether the medicines are showing good response or not. So that is the outcome. Okay, how much improvement patient is showing. Good prognosis means good outcome. Patient functioning will improve. Poor prognosis means patient functioning may not improve. Okay, patient may just sit idly, not do much. Okay, so some factors can tell you whether patient outcome will be good or it will be bad. Okay, so what are those factors? Okay, now let us discuss. So one is onset. That means how quickly the symptoms develop. How quickly the symptoms develop. Suppose family member says, doctor, he's having these symptoms in 6 months, but when the symptoms first develop, 3-4 days before the onset of symptoms, he was all well. And within few days, all the symptoms develop. So this is acute onset. Okay, so this is acute onset. So you can write down, so this is acute onset. So acute onset or abrupt onset, that means within few days, 2 days, let us say to around 2 weeks. So within few days or weeks, if the symptoms are developed, then we say it is good prognosis. Symptoms have developed suddenly. It is good prognosis. While if the symptoms are insidious, that is slowly, symptoms have taken months or years. So family members will say, doctor, although since 6 months these symptoms are there, but since last 1 year, 2 years, we were seeing some changes in him. He was not sleeping well, he was being irritable, he was not doing things normally as before. So gradually the symptoms have developed. Okay, so this is insidious onset. Someone who develops symptoms insidiously, we say, has poor prognosis, right? Now, depending on the age of onset, we have discussed already, someone who develops schizophrenia at a later age will have a good prognosis as compared to someone who develops schizophrenia at an early age, right? So second is basically the age of onset. Again, third, we have discussed subtype. We have discussed catatonic schizophrenia, paranoid schizophrenia have good prognosis. Okay, simple, habiphrenic, undifferentiated generally have a poor prognosis or a bad prognosis. Okay, best prognosis, very good. Worst prognosis, simple. Fourth point, based on gender, again we have discussed, females will have good prognosis, males will have poor prognosis, right? Now, if the patient has predominantly positive symptoms, okay, positive symptoms, paranoid schizophrenia has good prognostic, it has positive symptom, delusion and hallucination. So if there are predominant positive symptoms, it is good prognosis. Simple schizophrenia has predominantly negative symptoms. So negative symptoms have bad prognosis. Okay, so they respond less with treatment. Treatment response may be less. Okay, now the next 2 points are very, very important and sometimes confusing. So I want you to remember and highlight these 2 points. Okay, so we talk about effective symptoms. effective on mood symptoms. Even patient with schizophrenia can also develop affective symptoms like depression or manic symptoms. Okay, so if the affective symptoms are present, it is a good prognosis. Please remember this. So patient diagnosis is, we're not saying patient has full depressive symptoms. Only few symptoms of mood, if they are present, then we say it is good prognosis, while absence of affective symptoms is a poor prognosis. Why is this? Now we know that in schizophrenia, the emotions are lost. Patient shows no emotion. So if patient has some emotional symptoms, that means emotions are still left in him. That means his prognosis is still better. Okay, so please remember this. Please remember this point. They confuse at times, we get confused that if more symptoms are there, it should be poor prognosis. No. Affective symptoms, if present, are saying that the mood is not deteriorated very severely. Okay, so patient has good prognosis. Next and very important point again, family history. PFH is family history of mood disorder. If there is a family history of mood disorder, it's a good prognostic factor. So patient has schizophrenia. Let us say there is history of depression in the mother. We say it is good prognostic factor. When we compare it with someone who has a family history of schizophrenia. So someone has schizophrenia. We have patient. Many times we have patient. It runs in families. So we have a patient. The patient is having schizophrenia. Brother is having schizophrenia. One auntie is having schizophrenia. There are some symptoms even in the younger sister. So sometimes it runs in the families. So family history of schizophrenia is what it is telling, that more of genetic component is there, isn't it? And when genetic component is involved, the prognosis becomes even poor. Okay, so family history of schizophrenia, patient has poor prognosis. Please remember these 2 points, very, very important. Sometimes we get confused. Okay, I also told you how to remember. Okay, so this is very, very important. Put hashtag. Okay, write it down. These are very, very important points. Then next is, tell me, if someone is married, it is a good prognostic factor or a poor prognostic factor? Yes. In reality, it may be poor or bad, we don't know. But in schizophrenia, it is good. Okay, being married, no, I'm just joking, even in reality, it is a good prognostic factor. Okay, so married, someone who is unmarried or separated or widow. Okay, if person is married, he has social support. There is a social support. Marriage is also telling that his functioning was also good at one time. Okay, that he got married. Okay, then good social support is a good prognostic factor. In India, when patient comes, there are 10 people around him. So we can tell them, give regular medicine, take care of him. While in Western countries, people live alone at times. Okay, so good social support is a good prognostic factor. Pre-morbid functioning. Pre-morbid means before the illness, before the morbidity. If his functioning was good before the start of illness, it's a good prognostic factor. So patient was regularly employed, he was regularly communicating in his community, he was doing all his household work, everything he was doing before the start of illness. So that is a good prognostic factor as compared to someone who has poor pre-morbid functioning. Family members say, doctor, before the illness, also he would not work much. He would sit idly, don't do anything, not take part in any household. So his functioning before the illness was also poor. That is a poor prognostic factor. Last point is, someone who is employed is a good prognostic factor as compared to someone who is unemployed. Right? So again, this is a table, important table. I want you to remember this table. I want you to highlight this table. Okay, so this is very, very important. Please remember this. This is very important. Okay. When you're revising, do revise, especially these 2 points. The confusion lies in these 2 points at times. This is very, very important. Okay. Now we have discussed how to make the diagnosis. Let us discuss certain important points about the treatment. So in the treatment we use antipsychotics. Okay. So in the treatment we use antipsychotics. Okay. So we use antipsychotics. So there are two types of antipsychotics which we use. One is the typical antipsychotic or the first generation. One is the typical or the first generation antipsychotic. Second is the atypical or the second generation antipsychotic. Okay. So you can make them two tables you can make. Okay. So typical or the first generation, atypical or the second generation antipsychotics, right? Now, so these are basically divided on the basis of their mechanism of action. Okay, so basically we know that there is an increase in dopamine. Okay, so what do? We use dopamine, especially, so there are 5 dopamine receptors, D1, D2, D3, D4, D5. 5 dopamine receptors are there. Predominantly our target is D2 receptor, D2. So typical or the first generation antipsychotic are D2 receptor blocker or D2 antagonist. Okay, D2 antagonist. Okay, while the mechanism of action of atypical or the second generation antipsychotics, they are D2 as well as 5-HT. 5-HT is very good, serotonin. 5-HT2A. So dopamine was 2, even serotonin is 2. A, you can remember A for action. So the action is 5-HT2A antagonism or blocker. So it was only D2, here it is D2 and 5-HT2A. A, you can remember action. Mechanism of action is blocking 5-HT2A as well, right? Now, so it is only blocking D2. Because of the blockage of D2, we get EPS. What is EPS? Extrapyramidal symptoms. So more EPS is seen with typical, less EPS is seen with atypical. Okay, so the motor side effects are more common with first generation than with second generation, right? While the metabolic side effects are less with typical ones, so there are also some metabolic side effects which are less with typical, and those are more metabolic side effects with. Metabolic side effects means the metabolic profile is deranged. Patient may develop obesity, patient may develop diabetes, patient may develop hypertension, patient may develop hyperlipidemia. Okay, so these are the metabolic profile which is deranged. So weight gain, diabetes, hypertension, these are more common with the atypical one, because it is also affecting other receptors like serotonin. Okay, so this is important, right? Please remember this. Now, let us discuss some important drugs. One important drug is haloperidol. Haloperidol has maximum D2 antagonism. One of the drugs with maximum D2 antagonism, so it shows one of the drugs with maximum EPS. Okay, so it is one of the drugs with maximum EPS, right? Then next is chlorpromazine. Chlorpromazine, other than D2 activity, it also has anticholinergic property. So anticholinergic side effects are also seen. Blurring of vision, constipation, urinary retention, dryness of mouth. Okay, so all the anticholinergic side effects which you have read can be seen with this drug. Okay, so there are many drugs. These are some of the drugs with in typical antipsychotic or first generation. Okay, haloperidol, chlorpromazine, right? Okay, so this is typical. Now, second group is atypical. So drugs like olanzapine. First is olanzapine. Very commonly side effects like weight gain, increased weight gain, or metabolic side effects are very commonly seen with olanzapine. Okay, no, please, no, you don't say which is the drug of choice. We don't say one particular drug is the drug of choice. We say any of these can be used depending on the patient profile. Okay. Second is risperidone. Second is risperidone. Okay. Second drug is risperidone. Now I told you that second generation antipsychotic have less EPS, but out of the all these atypical ones, we say maximum EPS is with risperidone. Okay, so out of all the atypical ones, we are saying maximum EPS out of the atypical ones, right? Third is aripiprazole. Third is aripiprazole. Okay, third is aripiprazole. EPS is extrapyramidal symptoms. Okay, aripiprazole. So one important point I want you to remember is the mechanism of action. It is a partial D2 agonist. So it's not in particularly a D2 and 5-HT2A antagonist. Slightly different mechanism of action, but still we keep it under the atypical one. Some books say that put it under third generation antipsychotic, but mostly we keep it under second generation or atypical antipsychotic. Okay, so it has slightly different mechanism of action. Aripiprazole. Okay, then next important drug I want you to remember. This is a very important drug. Clozapine. Very important. Clozapine. Remember, it's not clonazepam. That's a benzodiazepine. It is clozapine. Okay. Now, in fact, clozapine is the D4 blockage is much more than D2. Okay, so the D4 antagonism is more, so more of D4 antagonism than D2 antagonism. One, you should remember. Okay, second point you should remember is where it is used. This is one drug. Now please understand, when you see, when we see prescriptions of physicians, they also prescribe a lot of psychiatric medicines, but no physician will touch this drug. No physician will touch this drug. This is the drug which we mostly used by psychiatrists because it has some severe side effects. Okay, that is why we say it is used only in treatment. It is only used in treatment resistant schizophrenia. So, you must have, when you read in medicine, the antibiotic becomes, the person becomes resistant to antibiotics. Similarly, the patient may become resistant to the conventional treatment. So you started olanzapine, did not work. You started another antipsychotic, let us say haloperidol, did not work. So we say if the patient does not respond to 2 or more antipsychotic, we call it as treatment-resistant schizophrenia. Schizophrenia not responding to conventional antipsychotic. In those patients, we start clozapine. Please remember, patient for the first time develops schizophrenia, we never start with clozapine. Clozapine is not the first drug to be used. It is used only in cases when other drugs are not showing much improvement. Okay, it is reserved only for those cases. So very important, it is used only for treatment-resistant schizophrenia. Okay, so these again, and maximum, please remember, maximum weight gain is with clozapine. Okay, so out of all the antipsychotics, if you are asked which is maximum weight gain seen with clozapine. If olanzapine is also there in the option, we'll choose clozapine. Okay, so very important, right? So again, these are some important drugs which we use for managing schizophrenia. Now, the duration. What is the duration of schizophrenia? Okay, if it is the first episode, patient has developed schizophrenia for the first time, so you start the treatment, patient is showing improvement, family member said, okay doctor, now is improved, for how long should we continue the treatment? You will say, even after improvement, we should continue the treatment for at least 1 to 2 years. Because if you stop the drug, there are chances. So first episode we say 1 to 2 years. If both are there in the option, we will say 2 years. Both are there in the option 2 years. If you are asked minimum duration, 1 year. Better answer 2 years. Suppose patient has developed episode second or more times. So family members say, doctor, 10 years back also he developed schizophrenia. Now he's again developed schizophrenia. To start the medicine, what will you say? For how long should we continue? Don't say lifelong. They will never come to you. We'll say minimum 5 years to indefinite. Yes, we may have to continue it for a long time. Say indefinite. Let us see. Let us see for how long should we continue. Okay. So 5 years to indefinite time. Okay. So this is the duration. Okay. So this was about schizophrenia. Okay. So this was yes. Yeah. I am saying duration of treatment. This is duration of treatment. Please remember, this is for how long should I continue the drug. Patient has shown improvement, family members are happy, but they, you should tell them it should continue. Because many times if treatment is stopped in between, they'll bring the patient again because symptoms have again occurred. So this is very important. Many times that is why people believe that psychiatric medicines are for lifelong. No, that is not true. Of course, it takes time. We continue it for some time. Okay. Next is some other psychotic disorder. Small topics, 5-minute topics are there. Okay, any drug, any of these antipsychotic, if we stop, can lead to relapse. No, that is different. Seizure may occur independently. Okay. Now, next is, this question has been asked in your December 2020 exam. A very beautiful question was framed out of this very small topic. Now, we have spoken about schizophrenia. Suppose a patient comes to you, doctor is having delusion, he is having hallucination, but the symptoms are only present since 15 days. What will you do? Will you tell the patient, go home, when 6 months are crossed, then I'll treat you? No. We will say, okay, we'll treat you. What diagnosis we will make? We'll make the diagnosis of acute psychotic disorder or simply acute psychosis. So from the term itself, acute means it is occurring for short duration. Okay, symptoms are developed for less duration is there. So here the symptoms are similar to schizophrenia. Patient may develop delusion, hallucination, disorganized symptoms. Okay, but it is not fulfilling the duration criteria. Important. The duration criteria is not getting fulfilled. Okay, so this is important. The duration criteria is not getting fulfilled. Okay, so patient may be developing symptom for 15 days, 20 days. Suddenly the symptoms are developed. Now this one point I want you to remember, that sometimes acute psychosis may be associated with some stressor, with some event. For example, it may be some certain life event. For example, there is death in the family, patient had a breakup, okay, patient lost his job. So certain life events can also precipitate psychosis. So, and also sometimes please remember this point. Patient sometimes may develop psychosis. Initially there may also be fever. Why I am stressing this is sudden onset of symptoms, patient having delusion, hallucination, associated fever. Sometimes you start thinking about delirium. Delirium we discussed, it may be with infection, with other abnormality. You start thinking about organic cause. But it will be only delirium if there is impairment of consciousness. The examiner will be very clever. He will put delirium somewhere in the options. The question which was asked recently, it also had delirium, but the stressor was not any fever. Okay, so it was easier. But sometimes they may also give fever. If you have to choose delirium, always it has to be impairment of consciousness. If not, then it may be acute psychosis. Okay, right. Now, in DSM-5, again, DSM, what is the duration for schizophrenia in DSM-5? 6 months. So if the symptoms are less than 1 month, they call it as brief psychotic disorder. brief psychotic disorder. If the symptoms are less than 1 month, right? If the symptoms are present for more than 1 month, but less than 6 months, then they call it as schizophreniform disorder. Both these are acute psychosis. Just the terms which are used in DSM-5. Both of them are acute psychosis. Less than 1 month, brief psychotic disorder. More than 1 month, less than 6 months, schizophreniform disorder. Treatment, antipsychotics. Okay. We treat antipsychotics. Okay. So this was about, again, this is a very small topic, just one slide topic, but many a times asked. You may get this as the options. Okay. Recently in December 2020, direct question from this was asked. Very good question. We'll discuss that. Last, okay, write it again. Last topic. Okay, just see the previous slide. Last topic, then we'll end for today. Okay. Delusional disorder. Delusional disorder. Now, please remember. Okay. Just see again. Okay, write it down, then we'll start. Delusional disorder. Go back to the criteria of schizophrenia and tell me, if the patient is only having delusion, can we call it as schizophrenia? No. Why? 2 or more symptoms. But many a times patient develops only delusion, no other symptom. What diagnosis should be made? What is the diagnosis? It is in acute psychosis also symptoms similar to schizophrenia. Only duration is not fulfilling. But if patient is having only delusion, no other symptom, diagnosis is delusional disorder. That is why we have made the entity. There is no disorder as hallucinational disorder, because we don't clinically find patient only with hallucination. Okay, but yes, we find patient with only delusions. Okay, so there are 1 or more delusions which are usually related. So there can be 1 delusion, there can be multiple delusions. Okay, but they are usually related. For example, patient develops a delusion that my neighbors want to kill me. This is delusion of neighbor wants to kill me. Delusion of persecution. Patient also develop a delusion that my neighbors are talking about me. Delusion of reference. Patient also may develop delusion that my neighbor is having affair with my wife. Delusion of infidelity. So you can see many times these delusions are related. Okay. Sometimes patient may have 1 delusion, sometimes patient may have many delusions, which are usually related. Then it is delusional disorder. DSM-5 says the criteria is 1 month, symptoms are 1 month if it is present. If symptoms are, and ICD-10 says if the symptoms are present for 3 months. You may not remember this. This I was telling, okay. So you can remember that, 1 month, 3 months duration is only required to make the diagnosis. Okay. So one very important point which I want you to remember and highlight in your notes is about the functioning. I told you, tell me, how will be the functioning of a patient with schizophrenia? Very severely poor, poorly deteriorated, not taking care of himself, not going to work, not doing any household chores, very poor. But in delusional disorder, functioning impairment is usually normal. I'm not saying 100% normal, but it may be very few, 2%, 3% it will be affected. So you get a question, a patient, 30-year-old male, suspects neighbor wants to kill him, goes to his office regularly, goes in his community regularly. Only thing is he does not interact with his neighbor. Only that part of the delusion is not, his functioning may not be there. Otherwise, rest of the functioning overall is normal. It is suggesting it is a delusional disorder. Very important point, and many times this is given in the books. Very, very important, the MCQs, right? So these were some important other psychotic disorders, right? So this was about schizophrenia and other psychotic disorder. No, I can understand your situation right now. You may find that I hate every minute of my training, but this famous boxer said, no, I said to myself, and same thing I want you to tell yourself, don't quit, suffer now and live rest of the life, as a champion doctor. Okay. So, do you want to discuss important MCQs for the topics? Okay. So we'll quickly revise or we'll discuss quickly. All these are important MCQs which have been asked. Yeah, I'll share. You can find me in the social media. I'm present everywhere except for Tinder. I'm present everywhere. So you can just tell me. I'll share the question. Delusion is a disorder of which? Very good. Patient says, home is sweet, sweet in diabetes. Diabetes, urine, has smell, smell is hell. Flight of ideas. You can see that by chance they are connected. For flight of ideas, patient has to speak a lot of things. Okay. Decrease interest in pleasurable activities. Anhedonia. December 2019. Psychiatrists say, how is your mood? Patient says, my mood is up and down. It is not neologism, not clang association, not derailment, tangentiality. It's a controversial question. If any of you have doubt, I will discuss it tomorrow again. Okay? Drug of choice, Alzheimer's disease, donepezil. This was June 2021. Cognitive impairment means they're talking about memory. They're talking about dementia. Vitamin B12 deficiency. Let's be silent for some time because these are important questions. You should know how to attempt. Elderly male diagnosed with Alzheimer, transmitter reduced in this condition. Look, direct question. There is no difficulty. You should be able to solve such question. Acetylcholine, very important. This was the beautiful question in 2018. Which of the following is seen in catatonia? How many if you say cataplexy? How many if you say cataplexy? It is catalepsy. Positivism? It is negativism. Disobedience? Automatic obedience. So answer is echolalia. Right? Capgras syndrome? Familiar person, close person replaced by stranger. A. What is B? Fregoli. What is third? Famous person is loved with the patient. D. Clarenbolt's delusion of love or erotomania. Wife cheating on the patient, delusion of infidelity. Now, so if you want to leave, you can leave just 5 minutes. I'll discuss. You have exam in December. How should we plan it? Okay, please understand, if you have a plan, more chances that you will go to reach your destination. If you don't have a plan, you may reach, chances are you may not reach. Okay, I'm not saying without a plan you cannot do, but with a plan, things become even better. Okay, so two things which I want you to remember is to plan and to be persistent. Just having the plan will not do anything. Okay, I have a doctor, I have made a good plan, sir. But if you're not implicating on that plan, nothing will happen. Okay, no, as people say, heroes are not made by the path they choose, are made by the path they choose, not by the powers. Iron Man was the person we see in Avengers. He was the one who was a human. There were gods also there. He was one of the most favorite ones. He was the one who killed finally Thanos. Right? So what path you choose is more important than your powers. You may feel that, I cannot, other people are more intelligent. No. If you choose a proper path, you can succeed. And believe me, we have seen students who were average or maybe below average in their MBBS lives, but they have exceedingly done well in their exams. In fact, even when we see PG students, they've even cleared very good competitive exams like AIMS as well. So you can do that. But you have to have a proper path for that. Okay, a plan for that. Now, when we make a plan, very small thing I'm telling you, very simple thing. When we plan, so we can plan for a day, a week, and for a month. This simple concept will be applicable when you plan for a week and when you plan for a month. The thing is, first of all, is before the start of the day, plan it before in the night. When you wake up, many times we lose 2 or 3 hours just deciding which subject to start, which topic to start, and afternoon has already set in. Okay, we lose crucial time. Before sleeping, decide what I will read tomorrow. Be sure, be clear. Okay, now when you are in the morning time, suppose your full day, there is no class. Afterward, when the classes will get over, you will get these time. You will get full days. Okay, start with topic which is difficult or which is boring to you. I'm not saying don't start, don't start doing something which is very difficult and never asked in the exam. I'm not saying to start such thing. Out of the topics, so every faculty will tell you important topics. Out of this, decide which is difficult for you and start. Okay, by the afternoon, when you have over with those if you do opposite, by the end of the evening, difficult topic like you say, oh, let's do it tomorrow. That believe me, that tomorrow will never come. Okay, that and when you will give the exam, those topics which you have left will be haunting, will be there in your unconscious memory and will be affecting your MCQ. Okay, so very important. And always revise important topics or important points of the day. Very important. Revise important point. Revision is very important. If Virat Kohli has to make 100 runs, he cannot just sit and think. What he has to do is he has to practice. Okay. Similarly, when you have to prepare for your exam, you have to revise. Revision is the only strategy. You think, doctor, I just keep a book inside, below the pillow and sleep. I wish that, everything comes to my mind. No, this thing will never occur. There is only